chondrocytes have the function only to repair cartilage. Chondrocytes does not repair the bone. Same thing, the osteoblast does not repair the cartilage. So this process goes up. Next slide, please. So if we divide, there are three different type of cells in the body. Those are totipotent, pluripotent, and multipotent. So in the next lectures, you will hear about the different type of cells. So I just wanted to briefly mention. Next slide, please. So pluripotent cells can give rise to all the cell types that make up the body. Same like the embryonic stem cells. The embryonic stem cells can create an entire human being. But whereas the other cells have very specific functions. Next slide, please. Now, the adult stem cells, which usually nowadays are being allowed to inject, infuse, not the embryonic stem cells. Embryonic stem cells, they have been a clamp, mostly in most of the countries. They don't do it, they do it only for the sake of the research purposes. Because if you give embryonic stem cells, the chances of formation of teratomas are very high. So the people who are using are the fat cells, bone marrow cells, and different cells which can create the specific function wherever they are injected. Next slide, please. Now, mostly people are dealing with in the bone marrow, there is amount of mesenchymal stem cells. These cells can divide accordingly into adipocyte, chondrocyte, osteoblast, neurocytes, and cardiomyocytes, depending on how the growth factors they stimulate in the lab. Next slide, please. Now, again, this has been mentioned a long time back, somewhere in about late last century, bone marrow transplant started. This is what we believe, that bone marrow transplant was the first transplant for the stem cells. It is not right. Next slide, please. So, the unique properties of the stem cells, they are unspecialized, capable of dividing and renewing themselves for a long period of time, can give rise to specialized cells. Same like the mesenchymal stem cells, you stimulate, you can get osteoblasts, neurocytes, and whatever it is. Next slide, please. Now, an adult has got about 2.6 kgs of bone marrow entirely. So we usually, whenever we aspirate bone marrow, we aspirate from the iliac crest. So this is the amount, and as we age, the amount of bone marrow is reduced, and the bone marrow has got only next slide, please. About 0.011 or 0.01% have got mesenchymal stem cells. So this amount of cells, they self-divide, reach the site of the injury. So in the lab, what we are doing is, we are isolating these mesenchymal stem cells from the bone marrow and divide the cells accordingly. Next slide, please. Now, this is the evolution of disease management. In 1800s, every disease part was removed. In 60s, we started replacement, like hip replacement started in 60 by Charlie in London. Then by 1980s, we had this tendency to repair. Regeneration started in 2000, because 1998, I said that was the first time when we had this isolation of the embryonic cells. But 2020, we are supposed to reproduce, and already they are reproducing cartilage like meniscus on a scaffold, reproducing bone on, reproducing skin. This is going on. Next slide, please. Now, this was the old concept that the stem cells is something new. Orthopedic surgeon, Dr. Albi was an orthopedic surgeon. In 1909, he used the first bone graft to put for a healing of a tubercular spine. And that was the first time in history, without knowing that the bone graft and the bone marrow had stem cells, has been used. Next slide, please. Now, this was the copyright for us. This is what standard we do. This was 2017 we had. Usually we take bone marrow from the iliac crest and go through the process of different stages, and then in about 2 weeks we can cartilage cells, in 3 weeks osteoblast, and about 2 weeks neurocytes. And then we inject accordingly wherever we want to cure the disease. Next slide, please. Now, presently, because we don't have the answers to all the questions of the diseases, so now the concept of precision medicine came. Individual treatment modalities has to be done. Next slide, please. So the clinicians and scientists continue to investigate new ways how can we treat patients, how can we improve their quality of life. Like patients who are infertile, how can we make help the ovaries to produce? How can we make the osteonecrosis heal accordingly? How can we make osteoarthritis go away? So these processes have been started. Now it is coming into force. Next slide, please. Now, why it's so important to all of us? Because we don't have answers to many of the diseases. We treat only the symptoms. We don't treat the disease. So that research has become more and more important. Now the concept of this get-together today was to spread the knowledge which we have, whatever knowledge we have. We've got very eminent speakers from all over the country and outside the country, so that they can shed light for the physicians who are practicing, so they can improve the practice and cure the disease and improve the quality of life of the patient. Next slide, please. Now, and surgeons. And still US FDA, now the government has clamped it. Most of the countries, like before, I used to send a lot of patients to Ukraine before the war. Like treatment of autism is the best center available there. That is the reason why stem cell therapy has become very important. Next slide, please. Now, I'll just go through a little bit in each disease. Like cardiac disease, it is very important and still being practiced in many centers. Not only, I don't know about Indian subcontinent, but I know in Vietnam, in Thailand, and in Malaysia, other places, it is being tried. What it does is, the main goal is to repair the damaged myocardial tissue so that it can improve the ejection fraction of the heart. Next slide, please. Now, digestive diseases, definitely there are two. Crohn's disease and inflammatory bowel disease, there is a standard treatment now. Most of the countries are following. Like 90% of the patients demonstrated sustained remission after a follow-up of about 2 years. A single injection of mesenchymal stem cells, IV, can ameliorate the symptoms with a follow-up of 2 years. And again, after 2 years, they can have another injection, whereas they can improve their people who suffer from Crohn's disease and inflammatory bowel disease know how bad they suffer. Next slide, please. Respiratory disease and lung fibrosis. The COVID gave a push in that direction. Now, patients who have respiratory failure and fibrosis because of COVID is now improving because of the mesenchymal stem cell injections. Not only IV, they are mixing it with normal saline and injecting directly through the bronchoscope area where it is damaged. Next slide, please. Now, chronic disease, kidney disease, is a huge issue in every part of the world. Now, to date, there is no significant breakthrough, except again we are controlling the symptoms, or doing hemodialysis, or in the end patients are waiting for a kidney transplant. Next slide. I would like to quote this very important publication which came in 2021 in Stem Cell. They suggested that the mounting evidence from the administration of stem cells in experimental kidney disease suggested that the cell-based therapy have therapeutic, reproductive effects in the kidney damage, in chronic kidney failure. Next slide, please. Even in acute kidney failure, this is a very interesting, people who are dealing with nephrology. Probably this is the best paper I have read, where 9 different universities, from John Hopkins to Mayo Clinic to Cleveland Clinic, all of them were involved. All, you can go through the paper, I have a copy of that, I can give it. All different parts of the US, they were involved in the study. Next slide, please. And they showed that bone marrow mesenchymal stem cell alleviated inflammatory response in patients with acute kidney injury. This is the mode of the action. These are the 2 clinical trials. That transplantation improved disease activity and renal function and reduced the proteinuria as well as no adverse action happened. So the renal function improved, proteinuria decreased, and one of the Indians who was heading this research, Dr. Swaminathan, involved 9 different top universities in the US and conducted and showed that in acute injury, probably this is the best treatment available by the time the acute kidney injury becomes a chronic kidney injury. Next slide. Now, in this forum today, we have one speaker coming. He has already sent his invitation from Vietnam, Professor Dien. He is one of the Asian scientists of the years, and he has got so many patents to that. And then we will hear from one of the professors about assisted how stem cell can be used in assisted reproductive technology. We have a lecture on neurological diseases, diabetes. There are 2 speakers because diabetes is so important, type 2 particularly. And I'm sure about 30% of all Indians suffer from type 2 by the time they reach 50 years of age. Osteoporosis of the femur, very important for orthopedic surgeons. We have osteoarthritis of the knee and sports injuries, and the spinal cord injury. These are, apart from their own clinical trials, the present data of 2024 will be presented, where we can learn what the other people are doing and how the meta-analysis is working. Next slide, please. Now, I have seen in my life a lot of skeptical people. You talk to them about stem cells, they say, no, come on, you're talking nonsense. It is not like that. This is how, long time back, even this telephone is, I think, before my time. This is what we used to use. Next slide, please. But now, we have smartphones. Why it came? Because there were innovation, there were development, people started to think. And that is the reason why we are here, our lives are much more comfortable. And I think probably the stem cell therapy will take us there. Next slide, please. So, then you tell, even physicians I'm talking about, not this group. If I go anywhere else, they said, come on, don't talk to me, I have made up my mind. And then you are confusing me with whatever data you are giving me. But it's not right. We have to keep our minds open to learn something. Next slide, please. The regenerative medicine revolution is upon us now. We as physicians have to push to improve the quality of life of patients. You see, like iron and steel was to the industrial revolution for the infrastructure. Then came the microchip to the tech revolution. And I think, and I strongly believe, that stem cells will be the driving force for the revolution of curing incurable diseases in the future. If we take a step now, probably in the next couple of years, things will improve. Unless we do that, then the coming generation will blame us that these stupid people did not do anything. We have to go back and do it. Next slide, please. Everybody knows this guy. He said that it's not that I am smart, it is just I stay with the problems longer. Because he wants to stay with the problem. And to his statement, I added my statement. Next slide, please. And I want to stay with the problem longer so that I can attempt to solve them, not to push it into a corner and throw it in the dustbin. He said that he wants to stay with the problem so that he can understand the problem. But me, I want to solve the problem. Next slide, please. I want you to read this. Now, Dr. Sadat, you left the stem cells sitting on too long. Now they are not good because already they have become kids. Thank you very much. This is our lab.
Thank you very much. Thank you very much. Now, again we are getting connected to Professor Firdaus. I hope we will hear him by Zoom.
If you have any questions, let us spend a little bit time so that they can connect.
इधर लाए नहीं है ये इसमें
Any questions?
I have done the cases in my association.
Please sit down.
Thank you, sir. So, how about the grade 3 and 4? Is treatable with stem cell?
लैपटॉप में दिख रहा है
And what is the best? Because we almost lost the regenerative cells there at grade 4 as compared to 2 and 3. So, do you think it is doable with the stem cells?
I will come back and show you our trial what we did. But it is international consensus is there. Some of the grade 3, if the cartilage is not completely gone and if they don't have deformities. If a patient has got varus or valgus deformity, it cannot be cured. Because only one side has got deformity. But stage 1 and 2, now for osteoarthritis, it has become standard of care, not point of care. Most of the stem cell therapies are point of care. Osteoarthritis has become a standard of care.
नीचे ऐसा कैसे दिख रहा है ऐसा ही
The cartilage, I will show you the follow-up of one study of Joe in Korea, where they did arthroscopy and MRI.
नहीं अभी
3 months, 6 months, 9 months, 24 months, and even they took a biopsy from the ulcer which has healed. So osteoarthritis 1 and 2, definitely some patients 3 without deformities.
Thank you, sir. And how people are aware of this, that is 1 and 2, because physician or doctor or orthopedic surgeon, they say you have to go for knee replacement, rather you will delay. So 1 and 2,
That is,
that's true. So must be awareness is required in the patient that that 1 or 2 can be treated with the stem cell. That is lacking, I have found so far in my experience, because patient has no belief on stem cell doing if they have in grade 1 or grade 2. They will go up 3 and 4, okay, I have to do something on that.
I'll give you one example. Once they are ready, they will stop. You see, in US, as of last year, 30,000 people died, those who were having osteoarthritis. Why? Because of they were taking non-steroidal anti-inflammatory drugs and they started to bleed. In India, I'm sure the number is very high because we don't have postmortems here. At least in US, they do postmortem, they have found perforated ulcers and everything. So 30,000 people dying with using NSAID because of the osteoarthritis, it is, to me, it's criminal. But physicians should be on the front line to put all the facts on the table for the patient. That look, we have this option, this option, this option. and you choose it. If you want me to choose for you, I will choose the option which is cheapest.
Thank you, sir.
Yes.
क्या बोल रहे हैं?
So my
मेरा
question
नंबर ले
is
लो,
related
मेरे
to
को
what
में देख लिया तो बोलते मेरा
you
मोबाइल
said about osteoarthritis, osteomyelitis of femur. What are the applications in cases where we see partial tears of tendons like rotator cuff or knee joint ligaments, where we advise for conservative management with physio and all, but the joint stability and that still won't come back like how it is naturally. So is there any chance of treatment for such cases?
You see the literature, I will be talking because of shortage of time. I combined my two lectures of sports injuries and the osteoarthritis of the knee together. Meniscus injuries and ACL, partial tear of the ACL, have been shown to heal by themselves. Even I have treated because I put facts in the partial tear of the tendon Achilles. It heals completely. But if you add, say, mesenchymal stem cells or chondrocytes to it, the healing is quicker. You don't have to keep him in plaster for 3 months. Rotator cuff, unfortunately, I have not done, I have not tried, so I cannot say anything more, but even literature is not there. You see, people are treating stem cell in young active adults. So probably, a rotator cuff might be, it needs a repair. It needs, last night we were discussing about rotator cuff injury with Professor Azam, who will talk about the osteoporosis later. You see, now they want to repair everything. It's not necessary to repair everything. There's something you have to leave it to the nature to repair. And then the patient can live with some disability, not too much of disability. I mean, 20 years ago, don't you think we had elderly people having rotator cuff injury? They lived a normal life and died normally. So now we are adding insult to injury by repairing them and creating complications. But young people, yes, I agree that there has to be a repair. And yes, sir.
In your practice, actually my question is quite close to what Ms. Lipi Singh has asked. So in your practice, how many patients get convinced in grade 1 and grade 2 go for stem cell? This is question number 1. Question number 2, that do you think the physicians who are now practicing, especially in orthopedics, they should tell the patients that we have a stem cell therapy where you will see if you take it now, you will be kind of saving yourself in going into grade 3 and grade 4. So how much legal is that to say, or do you now suggest the young physician to do that?
My own practice and what I have read from the literature, unless you tell the patient each treatment modality, what are the pros and cons, what is the benefit, what is the cost. Like osteoarthritis, I can tell you, I have injected about 5-6 years ago. They never came back again. Never came back with the pain. They stopped using non-steroids, even Panadol. They are doing routine, walking and limited physical exercises they used to do. But also at the same time, you have to counsel them. The activities which created the injury to the cartilage has to be stopped. The weight reduction has to be there. Supportive therapy has to be there. You see, like when we treat osteonecrosis in sickle cell disease, for 2-3 years they will be okay. But again, there is any crisis and insults again, like a patient with alcoholic induced osteonecrosis. You treat him, he will be fine for 2 years, again he goes back and drinking alcohol, again the insult can come. So even in osteoarthritis, you have to counsel the patient, you have to watch your weight, see that you do activities and don't do extra activities which will injure the joints again. Stem cell is not a silver bullet. It is a treatment added to the other supportive treatment has to be given. And we as physicians, I think we have to counsel the patients. Unless we counsel the patient, give them all the options. You see, like you come to me and ask me, I want to go to, say, Nizamabad. Okay, I'm a trial agent. I'll tell him, you can walk, you can take a cart, you can go by horse, you can go by camel, you can go by train, you can go by bus, you can rent a car. So those things have to be which you are convinced. Why are we not convinced? Because we don't have time. We don't have time to read the literature, unfortunately. Unless we read what is going on, what is happening, no, our practice will become inject, when he's not happy, replace the joint. If he gets infected, do the revision. So, it's a dominoes effect which we have to stop. Thank you very much for listening.
बैटरी जा रही है चार्जर कनेक्ट है बैटरी What's happening?
needs to open the presentation.
They have to open it.
No, he needs to. उनका presentation open है.
Can you open the presentation?
Yeah, I can see now the presentation is shared.
So click, double click करिए, open the presentation.
I may already open है. I can see.
Can only see the presentation. आपको double click करिए.
What I do, can I send through the email presentation? Hello?
I think you have to share the screen and start.
What I do, I send through the email to you. You can just share it. I can talk from you.
Presentation नहीं है ना आपका?
नहीं, that I can send you through the email right now.
भेज दीजिए फिर. Presentation ही भेज दीजिए.
Because what happens is not sharing. That's the problem.
Presentation भेज दीजिए. हाँ, करा दीजिए.
In the meantime, now still there are some problems with sharing of this information and these slides. Ms. Chalak can continue her session, the last part of the session, then we will come back.
Hello. Hello everyone. We already know about the stem cells basics. Firstly I introduced myself. Myself Jhalak Nema. I'm a cell culturist and junior scientist. All know about the stem cells, sources of stem cells, basic stem cells. I'm going to introduce the stem cells. This might contains like what is stem cells characterization, types of stem cells, potential benefits, source of stem cells, and conclusion. Now I'm coming with the stem cells. What is stem cells? The stem cells are biological cells, mother cells, and we can say blank cells. They don't know like what they're going to do. So we need to switch the button for continue their property. Has that unique ability to self-renew itself, multiple cells of same type, and also we differentiate it into any type of cell in our body. Stem cells have potential to regenerate the medicines as they can be used to replace or repair damaged tissues and organs. They are thus studied for their therapeutic application in treating a variety of medical conditions, including degenerative diseases, injuries, genetic disorders, and however, the ethical consideration has technical challenges continue to be important aspect of stem cell research and application. So this is all about the basic of stem cells, what we know. The stem cells characterization has six different properties as unspecialized cells. It doesn't have any tissue-specific study that allow it to perform specialized function. Differentiation is certain physiological experimental condition that unspecialized can give rise to a specialized cells, including heart muscle cells, blood cells, and etc. The self-pruning property is a must. Can be divided, produce identical daughter cells, and maintain a pool of undifferentiated stem cells. Proliferation is one of the stem cells characterization which we can capable of dividing and renewing themselves for indefinite period. Plasticity is also called as a transdifferentiation. It's one tissues may be to giving rise to a cell type, completely different tissue. Example, blood cell becoming a neuron. So this is the plasticity we call. And now the term is coming from stem cells, like they secreted some protein like cytokines, secretomes, and extravascular vesicle for the treatment of stem cell therapy, for the treatment of different diseases also. So these are the types of stem cells like totipotent, pluripotent, and multipotent, unipotent. So totipotent is can differentiate it in all cell type in a body, like example extraembryonic tissues and embryonic. They can form our body. The pluripotent stem cell, they form three germ layers, ectoderm, mesoderm, and endoderm, giving rise to all cell type. Example, embryonic stem cells and iPSC cells also. Multipotent stem cells, limited number of cell type can differentiate it in a specific tissue or organ. Example, adult somatic cells. They found in bone marrow and other adipose type derived MSCs also. Unipotent stem cells, they can only differentiate into one specific cell type, like example myoblast. These all the type of stem cells. This is a diagrammatic representation of sources of stem cells. We can represent the positive marker and negative marker. We can distinguish our stem cells from other cells like CD105, CD73, CD19. This is a positive marker. And negative marker should be CD45, CD34, CD14. This is the multilinear differentiation as osteoblast, chondrocytes, neuron, myoblast, and adipose tissues. We can also get our stem cells from bone marrow, adipose tissues, umbilical cord tissues, and iPSCs and dental plump stem cells and amniotic fluid. This is the sources of stem cells. Now, firstly, we call the adipose tissues very common in cell therapy. Adipose tissue is like a fat tissue, we can say. So this is a storage or energy storage tissue we can characterize in adipose readily available, and yield is higher number of stem cells compared to other sources of stem cells. The plasticity is abundant, like they are multipotent, meaning they can differentiate it into various cell types, including adipose, osteoblast, chondrocytes, and myocytes. We can also do different kind of cells also, like neuron also. The potential aspects of these adipose-derived MSCs with immunomodulatory property that can make potential candidate for the treatment of autoimmune disorder, inflammatory condition, and orthopedic applications. Has some limitation, is standardized for isolation, culturing protocols is essential, is ensure consistent quality and efficacy of the adipose-derived MSCs based therapies. Now come up with the bone marrow. It's similar of adipose derived MSCs. We can collect it from it's a soft tissue and sponginess. We can get it from hip bone. So the characterization is like same, similar is a pluripotent stem cells like adipose derived MSCs. They can included red blood cells, white blood cells and platelets. The self-renewing property is more in bone marrow derived MSCs because they replicate themselves through process called self-renewal and ensuring the constant supply of stem cell throughout the life. The hematopoietic function is different from other cells because they function is generated and repellents the various type of blood cells that circulate in the body. This process is hematopoiesis. It's called hematopoiesis. They occur continuously to maintain the blood homeostasis. The potential aspects of bone marrow derived MSCs is commonly hematopoietic stem cell transplantation, various like blood disorders, leukemia, lymphoma, and some certain genetic disorder, and we can also go with osteoarthritis also. Limitations, they aspirate carry a risk of complications such as pain, bleeding, infection. And one of the major limitation is like finding a suitable bone marrow donor to compare compatible human leukocyte antigen. We need to check with the HLA matching and can challenging particularly for patients for ethical diverse population. Now come up with the umbilical cord stem cells. We have two type of umbilical cord stem cells. It's umbilical cord stem cells get it from cord and placenta, and one from is tissue derived from Watson jelly. So this is the two type of umbilical cord stem cells. We get it from umbilical cord, and these are the some characterization we can define. The potential aspects is to treat the various blood disorders including leukemia, lymphoma and genetic disorder, and we also go for a sickle cell anemia and thalassemia. Now limitations has bone marrow requires surgical procedure. It's a non-invasive process to collect the umbilical cord stem cells to obtain some discomfort, and the number of stem cells obtained from bone marrow can vary, and this yield may be lower comparison to other cell types. This is one of the like menstrual we never heard like stem cells, menstrual blood stem cells. These are we collected from the shed of the blood from menstruation period time. So these are the characterization is multipotency have been shown to exhibit multipotent differentiation potential. They can differentiate in various cell type like same through others like they because they are multipotent. So we can differentiate into any other cell type. The high proliferating capacity is also there, so allowing them to expand the culture without losing their stem cells property, which is mainly a property of stem cells. The potential aspects, we can go for a gynecologist disorders, and some limitation is safety and efficacy is most of the therapy have been different. Now, this is the autologous bone marrow MSCs. Autologous means you are taking the cells from own body, and there are no risk of rejection, graft versus host diseases, which can occur using the stem cells from donor cells. It's allogenic source. Now upcoming slide is allogenic source. The heterogeneous population is more in autologous bone marrow. Contain a different type of cells, including hematopoietic stem cells, mesenchymal stem cells, and endothelial progenitor cells also is there. Potential aspects, it's like a same for other cells. We can treat the blood diseases and the leukemia, lymphoma, and other genetic disorders also. Limitation is like this a surgical process which carry a risk of infection, bleeding, and discomfort. The number of stem cells, which is yield also is maybe a lower comparison to other cell types. Now cover with the allogenic stem cells, we can take from genetically different donor, which lead to differences in human leukocyte type, and compatibility also is there between the donor and the recipient. Immunogenicity is is the allogenic stem cells may be triggered for immune responses due to difference in HLA typing, potential leading the graft versus host diseases or rejection. So the more limitation is in there in allogenic stem cells. The potential aspects, we can go with the commonly treated diseases, leukemia, lymphoma, and some recipient hematopoietic stem cells are healthy donor cells is necessary to treat the diseases. The major potential, we are talking about the stem cells therapy. So major potential of aspect of MSCs why we are using the stem MSCs because they are less immunogenic, potency is also without losing their cell potency. They can be used for toxic, potential treatment for the different kind of diseases. Cell specification we can do. Rate of production is much higher. Cell survival rate also is much higher in MSCs. Time, cost and safety is majorly defined in potential aspects of MSCs. The conclusion is the stem cells therapy hold up great promises treating the wide range of medical conditions, but the ongoing research and a clinical trial will fully understand the potential and addressing challenges associated with the implementations. So this is a collaboration with the researcher, clinical physicians. So we need to understand what the stem cells behave, and we are going to encourage our research. So stem cells has promising world, we can say, and summarize to learn. It's still much to learn among many challenges to overcome. The stem cells hold tremendous promises. And improving patients' outcome, transforming the landscape of modern medicines with continued research and innovation, collaboration. The stem cells therapy has potential to healthcare and offering new hope to patients around the world. So this is all about the stem cell resources. And thank you very much.
Thank you, Ms. Tilak. And if there are any questions for her, you can ask.
As a scientist, what do you think that which sources are better for the stem cell for clinical purpose as per your experience so far?
Okay, I had experience with the bone marrow. Basically, I don't have much experience when I was derived. The bone marrow has more potency because the surface markers also it's very, less immunogenic because of this. So major, I will go with the bone marrow for the clinical treatment, and we can get cells and we can expand more cells in bone marrow derived MSC.
So are you expanding the MSC from bone marrow?
Yeah.
Thank you.
Now there will be a tea break. We can have coffee or tea. Then we'll be back after 10 to 15 minutes. Thank you.
And then those cells took up the function, removed the toxicity of the which is piling up, causing neurotoxicity or sepsis, and then patient started recovering. Why? The reason is you have compensated the loss which has been made there by simply providing a time-based support. So I call it as he used as a liver dialysis technique. Liver's dialysis technique using cell therapy. So this was the first study which was published in the, next slide, in the transplantation, and it was beautifully, till now it is being cited like anything. Next please. Now the major limitation was this particular study and the total, it was a great talk in the medical fraternity that this is something like a new game changer, but everything just got stopped because of the limitation like cells. You cannot take all the time cost, take the fetal cells. No, it is not a right, but it was a transiently, somebody has proved the concept. So availability is a major problem because of the limited division. Then differentiate cells, it is difficult part, and the cell therapy limitations are listed here. So ultimately, to mobilize the cells into therapeutic model or therapeutic application, you need to have a big source of the continuous source of the cells in the condition which other speakers right now mentioned, that the QC has to be maintained, the quality has to be maintained, GMP production has to be maintained. All those things just came to a stall. There was a big talk in the government from the center that how this particular technology should be forward. The DST got involved, ICMR got involved, and then, next slide. So we kept on doing the other experiments that I will leave back. Now I will come to, I gave the background that why when we talk about mesenchymal cells, when we talk about embryonic stem cells, everything has a reason, everything has a priority, everything has to be chosen what exactly is required in this particular situation. As I told you, in acute liver failure, there is a crisis loss and you need to salvage that particular crisis. You need a big, huge amount of the cells which can take up the complete function of total body. But when you want that, you need to work on the cell process where you can multiply the cells. All those things are coming down, how the new technology is evolved. So the discovery of the embryonic stem cell gave a big hope that embryonic stem cells are going to give us a huge supply of the cells. Next slide. After a decade, I can say his publication came in 1981. Martin Evans and all these three people got Nobel Prize in 2007, and they published a paper sometime a decade back. But I just, next slide please. So this was the first publication which were made by Martin Evans, which was on the establishment of the culture in the pluripotent cells from the mouse embryo. And all those three people, go back please, go back please. So all these people, they were working on different labs, but they have a same data on the same line, and ultimately they shared Nobel Prize in 2007. Martin Evans came in 2002 in ITC Sheraton. We had BioAsia, and somebody just told in the dais, "Sir, we wish you that you should get Nobel Prize." And when he came on 2008, next slide please, next slide, next slide. 2008, he was already got conferred with the Nobel, and then he visited our lab, and Professor Habibullah was there at that time. So we had a long discussion on that. Next slide. Now I will try to now technically talk about the induced pluripotent stem cell, what topic has been given to me. That the discovery of the induced pluripotent cells, basically it is again outcome of the challenges faced by the embryonic stem cell. After the US federal government banned the embryonic stem cell, of course it had a lot of issues, so they banned it, and then ultimately scientists started thinking that what next, and then the discovery of these two guys came. Again a very beautiful story. I appreciate the passions of these people. Gordon did the work on the same line, and he published the paper in 1962. And Yamanaka published the paper in 2006, and when the pluripotency factors were discovered, then ultimately his work was got acknowledged. Next slide please. Now this is the paper which has been published by Yamanaka, induction of pluripotent stem cells from adult to fibroblast by defined factors. So basically this particular technique, in a very simple or common language, they talked about how a mature cell, how an adult cell, which I have told in my initial slide, in a limitation that differentiated cells cannot come to the immature stage. So here they made a factors, or they showed a factors that again you can reverse that particular thing from adult cells, you can change to the immature cell, and that those factors which he described, that was already done by the Gordon. Next slide please. I could not get the paper of the basically Gordon. When I searched it, I could only find this title, but the paper abstract was not available. I'm just showing the schematic diagram how it was done. So Gordon and Shanka first discovered the mature cells can be reprogrammed to become pluripotent, and discovered that mature specialized cells can be reconfirmed, become immature, so capable of developing tissues or of any body. These findings have revolutionized our understanding how cells and organizations can develop. So basically, we are going back from an adult to understand the developmental biology. And all these people who are the embryonic stem cell laureates and Gordon are basically developmental biologists, and that is the reason UK has a lot of contribution in the medicine, because they work on the basic aspect. They continue to do that, and they continue to dominate the total society because they continue to harvest the knowledge of the science. Next please. So these groundbreaking discoveries have completely changed our view of the development and cellular specialization. We now understand that mature cells does not have to be confined forever in specialized state. Textbooks have been rewritten. It has changed that completely concept there. And new research fields have opened the era. The reprogramming cells scientists have created new opportunities to study the diseases, develop methods and diagnostic and therapy. So can you imagine, as I told you, we are moving from an era of the pharmaceutical medicine to the era of the regenerative medicine. And now, when you understand completely, as he was rightly mentioning few things in that slide, that when you want to use your cells for anti-inflammatory, okay, these are the factors. He mentioned very clearly there. And if you want to use your cells for this particular, you have to check for this. The era is coming that we have to go as per the more of the factor based, not typically cell based or what you call some parameters which are endpoint like creatinine you are estimating. Or for the patient is dying, you are having the normal creatinine. You have a normal parameters, patient is dying. Because the molecular pathology which is changing inside, you are not able to get reflected in the peripheral blood. You need to understand what exactly the dynamic going on inside the organ. And that is the beauty of the newer era of the integrative research, where the high throughput systems are coming and you are able to understand the segregate the different histories of the diseases. And that is the beauty of the present era. Next one. Now, this is a very typical, as I mentioned that, very simply he did, like he has taken out the nucleus from this particular cell and he reintroduced from the other thing, tadpole. And then what he could get is the beauty part is that he got the tadpole here. And that was a concept he developed some 20-40 years back. 62 he published the paper, and this man is publishing it after, next slide please. And this man, same concept, he has taken that, he has taken out the nucleus, and now again he has proved that. Now beauty is that when a person is in science, he keeps searching what my area, other people have done it. And one easy path that you always try to take the lead what has been done. Next please. Now this has, as I told you, now the concept is coming like very easily that you harvest any of the tissue of the patient, grow it, and whatever you want it, you drive it, whatever type of cells. But again, just don't be very ambitious that it is going to be very easy. No. The reason is here, now comes here, this particular point, the intervention or integration of the pure clinician people who have experience about the cell biology. If you don't understand the cell biology, you will jump to the conclusion that, okay, I will use neuron, I will treat the Parkinson's, I will treat the Alzheimer. No, it's not possible. You have to understand the basics of the biology of these particular cells. And that is the most important thing. So, here comes the concept here. But the next level, I will talk about the laboratory part. How would you do that? Next, please. Now, these are the four factors. These are the four factors called OCT4. The terminology is like it is an octamer protein, and there are four proteins which are very, very important in terms of the development of any tissue. And nothing has been changed new. These are the factors which is normally occurring in any pluripotency when the cells are getting in a developmental stage. All these factors has been reflected in the work of the what you call initial embryologist, as well as those same factors has been used. Now you have factors, these are the factors now here, and now what you need is you need a cell. So cell from the init source. Now there you remove the nucleus. There is no need to remove the nucleus here. Nucleus has a DNA. Now I will come to a very basic part. Do you have a time?
Yes.
Time is there. No, yes, because I have to again speed up otherwise.
Yeah, I think we should.
So, the thing is that you have a factor which has been identified by the Yamanaka, now it is called as Yamanaka transcription factors. Now, what you need is any cell of adult nature. Now, this particular factor has to go in this side, inside this. And now there is a role here. There is a role here. If I want to introduce these factors, I have to use now a typical model where these factors can be introduced. That could be by reprogramming by using retroviral therapy factors. I will come down next slide, please. Now, this is a typical laboratory slide. These are the sources of the somatic cells. Any source you can use, like you can just take the blood and then segregate what exactly you want it. As Dr. Mahmood was mentioning, you have to understand, his slides were very beautiful. Now, whatever designing I want to do it, I can do at this level and derive my clinical application. So once we have a somatic cells, now these are my 4 transcription factor where we use this as a machinery, and after this, how do I introduce these cells into this somatic cell? Now I can use the approach like delivery method, integrative, like viral, non-viral. It's not that viral what you see in the application. It's a non-viral mediated factor transfer. Now you can use the non-integrative, again viral and non-viral, which will be only using to carry this particular factors inside this their genome and then introduce into your primary cells. That way. Now your cell, next slide please. Now your cells becomes a complete integrated into the host of the somatic cell. Now your cells will thrive and proliferate. Now here I come, I will explain because I thought there are many people who are not from the basic science. What does it really means of the transcription factors? As I again say that the era of the pharmaceutical science, or whosoever people now very much fascinated of the medicine, no, please don't get much fascinated with the medicine right now. Era of medicine is over. The young generation, there is nothing like medicine now. You have to enter into the molecular medicine. The reason is the era will be totally depending on the customized, personalized therapy. And there you cannot just use whatever the drugs which is being sold on the stalls. It will be totally precise as per the custom design of the patient. So the transcription factors, you first read that, I will show you the complete mechanism again. Transcription factors are the proteins involved in the process of converting or transcribing DNA to RNA. Then transcription factors include wide number of proteins, which could be excluding RNA, polymerase, and that initiate and regulate the transcription of the genes. One, the distinct feature of transcription factor is that they have a DNA binding domains, and that give them the ability to bind specific sequence of that particular host DNA called enhancer or promoter sequences. Some transcription factor bind to DNA promoter sequence near the transcription start site of the help to form a transcription median complex. Other transcription factors bind to regulatory sequences such as the enhancer sequence and can either stimulate or repress the transcription of the related gene. Factors pluripotency, as I mentioned, these are the 4 transcription factors which has been much talked about and that is going to play. Next slide please. Now this is a typical, whatever I'm talking, people not even understand that what DNA I'm talking. I just to make. Now what happens is that, as I mentioned, that molecular medicine. Now I can play with this particular total DNA. My one cell DNA will cover total Hyderabad. My one single cell, only one DNA strand will cover whole Hyderabad. That is one thing. So, but as I again mentioned that, we need to understand what is a trend. We need to understand what is required. We need to understand what the science is saying. We should not understand what is going on right now. So now you can see that I have taken a very small part of the DNA, but I was wanted to show you how one transcription things is going on and how I am reversing it back. Now what I can do is, you can bind your fracture here with the enhancer. Now the moment it binds here, this, because of the ladder, it is become more like a rope ladder, this sinks down. And this, once it sinks down, these two binds. And ultimately what happens, you can see lot of circles coming here. After that what happens, then the polymerase, which drives the total transcription, binds here. And you can see this particular protein coming. Now there is a one important thing that I will cover that part. If at all you have any sort of a gene silencing molecules, right now we are talking much of the era of this is we call as genetics. Now this is we call it as the epigenetics. There are many times what happens is because of some molecule this is blocked and you will not be able to transcribe, and that is called epigenetics. So this is one typical example, but I am trying to say that how transcription factors are activated to make it the mature to the immature cells. And this is basically one part of the gene regenerative medicine. One part of the, I can say right now, department of regenerative medicine will be use of the transcription factor. I did very simple experiment very recently. Understanding the developmental lineage of the liver and the pancreas, they come from the same term when they develop, endoderm. And when I studied, in our body, we share pancreatic progenitors in liver, and liver progenitor will be sitting in the pancreas. Now, I actually have published this paper. It's not this platform to speak. I started how I can make one liver lobe to the pancreas. How I can make one small lobe of the total liver to, and simply this transcription factor I have identified 3 or 4 factors which you can just change it, but I am talking to many what you call scientists where that liver can, a small lobe can be differentiated, and all this paper is my published. You can just search in the web.
Professor, I'm interrupting in between. You have 5 minutes.
Yeah, 5 minutes से पहले complete कर दूँगा मैंने अपनी पूरी. आप 30 minute बहुत है.
Thank you.
So now next slide please. Now I am coming to the data from that particular cell line. So iPS cell lines, before going for a clinical application, that iPS cells can be used as a model for that particular patient to develop against what drug he can be used. Whether that drugs can be resistant or that drugs can be sensitive or not. So that particular one of them, because clinical applications are known, I am just talking about where are the industries now moving in terms of the application of the iPS. Next slide please. It's a typical model, same way. You can take the blood and the way Dr. Mahmood has demonstrated that you can take the monocyte and then make it dendritic cell. Here what you do is you use the cell and then customize, once you grow them, customize accordingly your drug application and using for your corrected part. Next slide please. So embryonic, again, true stem cell is embryonic only, which has a complete characteristic, but as I mentioned, there is a lot of ethical issues and there are chances of teratogenesis, that is a tumor formation. None of the labs are more towards investing. In 2000, after that decade, Giron was the first company in the US who invested a lot on the embryonic stem cell, but none of the labs now working on the embryonic stem. Next slide please. Now these are typical, just compared with the two like advantage and limitation due to these iPS derived products necessitate comprehensive characterization, screening, genetic alteration to ensure their quality, stress and safety, and eliminates the there is some sort of ethical limitation is still there, but again it overcomes the ESC. And donor cells easily available and accessible to large number of once you grow them. Okay, so these are some of the concerns and advantages. Next slide please. Yeah. Okay, please go ahead. So this is a market like end user market in the, you can see the academic and the research, then you have a drug development, then you have the different applications like you can make all these cells, hepatocyte, fibroblasts and all these different application, but the market is more towards the even the research as well as pharmaceutical, and more like madam is talking about the products now. They want to always say why you are not making product in after. So madam, if you want your company to survive, you teach all people. Okay. She's after me all the time that Alin साहब जो है मैं बोलता मैं समझा रहा हूँ सबको इस्तेमाल करो, लेकिन प्रॉब्लम ये है we have invested on the medical degrees. We have not invested our resources on the creating science. We have not created a scientist at all. In the last 2 decades, I can say hardly there is scientists who can understand the basics of the biology. Next please. So these are the pure landmarks, year-wise, and these are the end products. Next please. Next please. Same. Okay. Next. Yeah. So these are the market growth. Next. Next please. Thank you.
I would like to add in the induced pluripotent stem cells. So definitely is a good new, you say, era of this section, and also highlight that these induced pluripotent stem cells will be used for drug screening at initial stage. Is from the patient-derived induced pluripotent stem cell can be used for drug screening at initial stage. What we are doing at this in pharmaceutical, the later stage clinical trial failure or you say the big investment involved, so it can be reduced with this initial stage induced pluripotent stem cells, either from the patients or normal, should be used for drug screening, so we can prevent the large investment and the failure of the clinical trials and approval. Thank you. It was nice presentation, Professor, so everyone will be educated with the induced pluripotent stem cells. Yeah, for physician, definitely it's a new thing, but for scientists, I think they're very aware of this.
I don't shy away teach basics because I try to see that whatever is there with me, I should transfer it. But always I say one word, that we have to get now change and make a sort of a awareness where the science is moving and create, yeah, the very important part I forgot to mention. Actually, you were telling me 5 minutes left.
Sorry about it, but
we are not creating a good skill resources. I am saying people are going toward a medicine and the techniques which are being taught, like the technique of immunotherapy, we don't find a good what you call biologist who can understand all those things. The graphs he was saying, I think hardly people would have understood. But there is a total one field of immunotherapy which needs people to understand how the T cell has to be isolated, how minus monocyte has to be done. Everything has to be done. Now, if you don't create this sort of a pool, how will you handle this industry? You will end up with Dr. Sada is coming with a huge investment. I am only worried about one thing. Sorry, sir. I am worried about only one thing. How I should support you when I don't have the good skilled people. So the more important that you don't have people like to understand 1% of monocyte he is talking. Total population of the monocyte in the body is 1.1%. And he is talking about monocyte derived dendritic therapy. Can you imagine? That is a question I was asking to more, like you have to harvest 0.1%, make it at least 10%, again differentiate it. You need a very skilled people who sit in the lab. I always appreciate my students who are female. I make them only to my lab. I don't allow male members to go to the one of the students is sitting here, he will say what. Because girls needs to be trained in immunotherapy, I tell you. We should find good people and work on that training these people. People are going towards different, we need to create awareness that how this sort of techniques. So you should also just put some efforts. I will support you because I am seeing a big people coming into Hyderabad, but they should all be supported in terms of providing skilled people. It's not so you tomorrow just add the bone marrow and tomorrow you will get it. Never it will happen. You have to play around. Experts are sitting here. Thank you, ma'am.
Thank you, sir. Thank you, Professor. So well said. We need skilled people to develop this immunotherapy or cell dialysis. Thank you very much. So our next speaker, Dr. Azudin, is one of the well-known orthopedic surgeons. Welcome, sir. Of Hyderabad, graduated from Hyderabad. He has a college, some scientific knowledge, willingness to propagate the recent advances in the field of orthopedics. He is practicing stem cell therapy in orthopedic practice from last few years. So he will talk about the importance of what type of cells are used in clinical practice. Thank you.
Thank you very much, madam. I'll say I'm honored. Dr. Sadat has given me a chance to be able to speak over here today. And I'll say the previous presentation was quite enthusiastic by Professor Alim and quite interesting for the persons who are interested in basic research. So firstly, I'll say as an orthopedic surgeon, many people have that misconception that surgeons are trying to push patients towards surgery and try to do more number of surgeries. That can be partly true, but what happens is you must understand the patients come to the surgeon quite late and come with the advanced stage of the disease. So most of the time when the patients come, they're already in, say, if suppose it's a knee arthritis patient, he'll already be in a stage 3 and stage 4 and would have already decided regarding surgery, and he would have come to you directly after having planned the surgery, rather than coming and meeting the surgeon early on might be when would have been a much better time for the patient. That is, might be in a stage 1 or 2, when the disease in its infancy and can be treated in a much better and I'll say minimally invasive manner. So I'll say my association with Dr. Sadat has been with for a couple of years, and I'll say my approach to patient has always been evidence-based according to what stage they come to me and what we can offer best to them at that point of time. So what happens is, now my today's topic, that is autologous versus allogenic stem cells, pros and cons. This is quite, I'll say, interesting topic. It's quite simple actually. I'll say it's not very complicated in the sense of talking, because this is basically a dilemma will come to the patient when he's interested to improve his health, especially when he comes in early and discusses his treatment options. Might be when he's suffering with, say, grade 1 or grade 2 arthritis of the knee. So what happens is, if the patient thinks that he's having any knee pain which is not resolved in, say, a couple of weeks with use of painkillers, and he comes to you, you tend to evaluate him with all sorts of investigations like regular X-rays, MRIs, and you come to the diagnosis, yes, this patient has a, say, primary arthritis, like cartilage disease is there, and then you try to offer him a treatment. So there are not very many treatments available readily for grade 1 or grade 2 disease. Most of the patients come to us using multiple NSAIDs and might have tried multiple supplements for this knee pain. So when we look at these type of patients, there are not many therapies which are there which can provide good and effective treatment which is sustained. Now of late there is an increase, I'll say surge in people giving platelet-rich plasma injections into the knee, which people are, I'll say patients are happy to take. Why? Because they think that they can get rid of their disease with a simple injection. Well, it is partly true, but I'll say regarding PRP therapy, it is not really very effective in the long run. It does give relief, but it is a very short term and not sustained. Whereas mesenchymal stem cell injections, if taken at the appropriate time and knowing correctly what it offers and what it can do for the patient, will be very helpful for the patient. Now coming to India, currently we have many multinational companies which are offering allogenic mesenchymal stem cell injections. Currently here in Hyderabad also they are available, but sadly to say there are not any which are providing autologous injections. So I'll say the stem cell lab is going to do a very big service to the society by being able to provide that service that is required. There are not many labs currently in India which are actually providing the same. So this topic is basically for those patients who are in a dilemma, who want to go for a mesenchymal stem cell injection and they are deciding on that treatment and they want to think whether to go with the autologous, that is bone marrow which is derived from their own body, or take injection which is derived from sample, a pool of I'll say mesenchymal stem cells which is derived from the general population. So next slide, I'll start this topic of mine. Next. Stem cell therapy is in use in many countries. As of 2021, as Dr. Sadat had told, more than 2,000 plus clinics have been providing this treatment in the United States alone. Many countries have been providing this. So India is a little bit behind already on the scene, but we are able to provide this to our patients now. Okay, next. So people who might benefit from stem cell therapy include those with spinal cord injuries, diabetes mellitus, Parkinson's disease, amyotrophic lateral sclerosis, Alzheimer's, heart disease, stroke, cancer, multiple sclerosis, and a plethora of orthopedic problems. Now, most of these patients will already be dejected because they feel that there is not a good therapy which can help them out. But this is going to, I'll say, good result can be obtained if they they are able to access the treatment in the right manner. Next slide. So as in Ukraine, this is a website, anybody can search online. All these websites are available, these therapies are available online. You can just check them out if anyone is interested. Next. Bone marrow, this is a slide related to mesenchymal stem cells. So this is just basics. Bone marrow derived mesenchymal stromal cells possess immense potential for the treatment of many diseases. This has been said time and again in this conference. Next slide. Bone marrow derived mesenchymal stem cells have become the gold standard. That is, this is a standard of care for use in many musculoskeletal therapies. Next slide. Question is whether to go ahead with allogenic or autologous stem cell therapy. Next. What is autologous stem cells? Autologous stem cells means the bone marrow from the patient who requires the treatment is harvested. We are able to make a small injection in the iliac crest, harvest the bone marrow and culture it in a lab, like a stem cell lab, and inject it back again into the same patient. So that is autologous stem cell. Next slide. If it is done from a pool which is derived from the general population, healthy population, it is called as allogenic stem cell. So allogenic stem cell transplantation involves the use of stem cells from someone other than the patient. This can be a person who's related to the patient or might not be related. Next. Allogenic stem cells. However, in more recent years, several groups have shown in different models that MSCs do induce anti-donor immune responses from different facets of the immune system, including dendritic cells, T cells, and B cell mediated alloantibodies. So what it means is basically if you take someone else's mesenchymal stem cell injection, the patient's body can provide like an immune reaction because it is not from native to the body. So there's an immune reaction which is possible, and this has been studied and presented all over the world. There are small number of studies describing several treatment emergent adverse effects following administration of decidual stromal cells or adipose derived stromal cells. Next. Allogenic stem cells. An allogenic stem cell transplant derives from a healthy donor. When using allogenic mesenchymal stem cells, donors are routinely tested for the presence of viruses as human immunodeficiency virus. But we are not able to test that sample in detail whenever you are going for a transplant. Transplanted MSCs can contain genetic material of other types of viruses. Next, MSCs derived from various tissues may contain other persistent viruses. Allogenic treatments may also pose ethical and safety concerns such as the risk of transmission of infectious diseases or viruses. The authors of this study found that MSCs derived from healthy donors contain viral DNA of parvovirus B19. Viral DNA has also been found in human bone marrow. The most common were B19 virus, tortinovirus, Epstein-Barr virus, Merkel cell polyvirus, and also human herpes virus. Next. After allogenic hematopoietic cell transplant, recipients are at higher risk of developing solid malignancies than general population. The reported cumulative incidence of solid cancers increases with age after the treatment. So initially 1.2 to 1.6% in the first 5 years, and almost up to 6% after 10 years, and almost 14% at 15 years, which is quite significant. Next. Pre-injection of allogenic stem cells, immune suppression has been tried so that the body can be sensitized to the immunity can be lowered. Addition of prostaglandin E2 has to restore the immunosuppressive ability, which has shown some promise in preclinical studies. In recent years, pre-treatment of MSCs with inflammatory cytokines such as interferon gamma has shown that these pre-treated MSCs have increased immunosuppressive ability in vivo. Next. It is important to understand how the MSCs are affected. Though by immunosuppression, the potential for efficacy and side effects of allogenic treatment has not been ascertained. Next. On the other hand, patients receiving an allogenic stem cell transplant are at higher risk of mesenchymal cell transplant because that is more safer for the patient. But if suppose time constraint is there and immediate requirement is there, then allogenic is better. Thank you.
Nice presentation, and everybody understand autologous and allogenic. The question open for the discussion if you have.
Yeah.
So when we are talking about the allogenic one,
Yes.
certainly there will be a ethical aspect, no, ethical concern.
Yes.
So how it is planned right now?
As of now, the companies which are providing this allogenic mesenchymal stem cell injection, they do give you a full disclosure of all the possibilities regarding infection and other problems which can arise. The patient is well informed of it. But I feel the patients, even if they read it in detail, they might not be able to understand it. So they do give a full disclosure, and they have an ethical review board before they give you the injection. But as it is a commercial transaction for the company, they don't emphasize much on the ethical part.
There are no conditions, in my opinion, where we need an emergent injection, stem cell injection. So why not wait for a month and give autologous in all situations?
See, my telling of that was not related to orthopedics in general. See, there are many conditions in which there will be a requirement for mesenchymal stem cell treatment. But it is not like, I'll say, in the purview of elective orthopedics. I initially had spoken about knee arthritis. That is purely an elective treatment. But there are some conditions which require, might be sometimes as an emergency or immediately, which is more correct word to use. So that will be there. So that will be a better time to think about allergen. Adil?
Yeah, no, not chronic, an acute condition like acute MI, myocardial infarction, somebody needs, there's no other therapy, allogenic is used. In acute kidney disease, kidney injury, renal shutdown, which has been used, and then also acute liver failure, allogenic has been used, and in the stroke. Recovery of the stroke initially may not be too much, but as time goes, allogenic autologous can be used. But in any acute conditions, people have used it. It's not that safety is the most important.
Yes.
Safety between autologous and allogenic. It's autologous is 100% safe. Might be allogenic is 50% safe.
Major issue with the autologous when you want to see, when you are taking from autologous at the age of more than 50, then that means the senescence will be there. That means the age of the DNA and that also will be there. When you talk about allogenic and from a cord blood, and you are getting a naive cord blood, and you are getting the passage 1, this will be having all those factors which we are talking. So ultimately, it is not basically autologous or allogenic. It is basically right time what exactly you need. Secondly, it becomes very difficult when you try to grow the cells. Sometimes you fail, and you need to harvest the cells in the same condition. So allogenic, when you are doing mesenchymal cells, then chances of all those things are less. Infections you can rule out once you take care, because right now in the preterm what you call diagnostic, major of the infections are taken care. So the time what you call stage 1 or 3, you will get all infection done. So the only issue is that your cells should be a quality. One patient called me from US and they told, can you arrange a cell for you, ma'am? Can you arrange a cell of cord blood derived mesenchymal cells of, he could not use the word passage, he told once something stage. And I told, what is that? No sir, pehla jab cycle hota. Well, where from you got this information? So he told that one of our company person, when I talked to them, he told, and that to mail delivery. So all that is not possible in India, it is very difficult. So there is a science of one thing. And in order to achieve acute condition, as sir has said, you need a compensatory type of thing. When your condition is chronic, you have sufficient time to manage. So that is, selection is very much important.
Is there any possibility of it, like cell bank or autologous bank? Cell bank or bank?
There is a cell bank normally.
Bank is there, but bank only release those cells when it is approved with the FDA, that indication. Suppose in autism case, it cannot give you the cord blood cells to you because this cord blood cell is not approved with the FDA application for in this indication, right? So that only for blood disorder, a government allowed to use the cord blood. So that in that case, bank will release the cord blood for you for transplant, but not other indications due to the rules and regulations of India.
No, again in autism, the parents' blood cannot be used, nor the siblings' blood, because they are carrying the genes of affecting autism. So in that, a matched control has to be done. And I have some experience. One of my colleagues, she had 2 children, and both were autistic. And they had to go to, I sent them to Ukraine, where there is a large pool of samples where they can match. Now, after 2 years, their recovery is complete. They are as normal as any other children. So it depends on very specific conditions, allogenic has to be used. Routinely, if I am using, I will use autologous for myself. But very specific conditions, you have to. There is no other choice except to use it.
Do you have in your lab this allogenic stem cell commercialization?
Yes, we have. It depends upon the doctor's requirement for a particular patient. So we have that manufacturing facility. So we are manufacturing those MSCs in our lab as well with controlled testing and all.
So do you also, share the information as Dr. Ejaz was mentioning that you provide the information about the GVHD or the post-injection complications?
So far for umbilical cord, water jelly stem cells, very hardly we reported any adverse effect for umbilical cord, especially water jelly. We have treated sometime autistic child as well with the water jelly. Sometime during after infusion, a mild temperature increase, some headaches are there, but it can be subside with the painkiller or something like that. But not severe adverse side effects so far has been reported from last 10 years we are doing in this.
I think so. His question was like, do you provide a disclosure to the patient? That was his question.
Yes, we have a proper consent form for the patient telling every cons and con of the using of allogenic stem cells.
Normally a printed consent is given declaring everything.
The signature of the patient and the doctor, transplant physician as well, and well consulting them before infusion.
Have you seen any acute conditions post allogenic?
No, let me ask you a question. Disclosures. I think everybody has opened a bank account, right? How many times you have read everything? Have you? No, we don't.
Just sign it.
You just sign it. You see, disclosures, there might be small prints are there, which either you don't understand and you don't have time to read. You sign for it. And then you sign. And then when something goes wrong, you go to the court. They will say, yes, this is, you have signed it. You have signed the consent, you have signed everything. So, particularly I'm not against allogenic, but I'm really, I want to be careful. If I'm starting a new procedure, I have to be very careful in my selection of patients. So here also, even though allogenic is in use regularly, I know 2014, there was a clinical trial in US on meniscus injuries where allogenic was used and everybody agreed. Same story, they did not even understand what they are signing.
Suppose if
So,
autologous culture fails, as I say, due to any reason, then what to do next?
And repeat again.
If it fails,
Yeah, see,
and again getting the samples from the patient is not that easy.
what I advise, honestly, if I am using, say, 2 hips I am injecting, so instead of 2 samples, I will take 3 samples. Hand solution, always, always there is a chance during your process of culturing it fails, you have always a sample. And again, when I take a sample of on the iliac crest, it takes 5 minutes. And patients, no GA, when I am passing the needle, it's a famous Jamshed needle, is still going on. When I touch the periosteum, that's the time they feel a little bit of pain. Once the needle goes inside, they don't feel pain. So it's hardly about 10 seconds, they are knocked off, and then you aspirate. So you keep always a sample.
only concern with, sir, I have a question for you. So bone marrow with the age, the number of MSC goes down.
Sure.
So how you can assure patient of 55 years of age for arthritis case go for this autologous bone marrow therapy?
If the MSCs are even less, like 0.00 to 0.01%, once you harvest the MSC, then you can reculture into the terminal cells.
Yeah, it's culturing the from the bone marrow is another. It's not totally autologous. Then you have putting the cells in the another environment.
Which is the mother cells are the same. You know, like initially I used the adipose tissue, but now all the research has shown categorically across the board the quantity of the cells in the adipose tissue is 10 times higher in the bone marrow, but the quality is less than 1%. So if I'm using 5 million cells from bone marrow, it is far better than getting 50 million cells from the adipose tissue. The quality is not.
But the age
you
of
can use, say, normally when you used to do, in order to that particular case, 3 days GMCSF injection. That what we'll see, this is a point. So basically, you mobilize from the bone marrow to peripheral and you increase the pool. So 5 days is a protocol in the hematopoietic settings. But in this sort of settings, 3 days or even 2 days also, you will get a good pool. And the moment you get this pool, then you harvest. Like tomorrow, if you're feeling that this person is going to have the less pool, 2 days you can give GMCSF and then take it out. Now what will happen is first point. When you are preparing a field, what cells you are going to give, because all these hematopoietic niche will be mobilized in the organs, and when you give it, automatically the cells will settle down. And they can say first thing that GVHD, for the discussion, none of the cell, let me just tell you, any cell with a blood component will only induce any sort of reaction. Mesenchymal cells and any cell will never induce any sort of a GVHD. Let me just tell you very clearly. This will never happen. I tell you very clearly.
Only in the lab.
No. I know. I'm telling. I'm telling about the GVHD will never happen. I see. GVHD.
In Ahmedabad, they use MSC transplant
Yes.
before the kidney
Right now,
transplant to suppress the immune.
Yes. Right now, see. GVHD, I will tell you very strongly.
MSCs are mode of function are 2. One is angiogenesis, the second is immune suppression.
Yes.
So if you are suppressing the immune, then the transplant will be easier.
Yes, that's
Yes.
Mesenchymal cells is as international few data here, but it is first of all, we cannot expect GVHD. Adverse, okay, could be of dose, could be of infusion, anything, but it will never cause GVHD in the use of allogenic, whatever it may be. That is my personal experience of last 20 years.
And it had never been reported in any literature so far.
No, there are, I beg to disagree.
But we never seen, maybe, maybe
No,
we
there
look again,
are
but
plenty,
You have
plenty of
literature, madam.
reports. There are plenty of reports of use of allogenic as a major complication of growth,
so maybe depends upon the sources of,
Depend on not only on the sources, the quantity, the quality, how much you are giving, why we are giving.
Right.
Locally it may not be very effective. If you are giving IV infusion is the main problem. Like in orthopedic we use for knee, we use only for knee.
right.
It does not come into circulation. But for any other reason, for say spinal cord injury, one dose is given IV. So they might go into the GVS reaction.
And also the harvesting of bone marrow.
Yes.
I mean, amount is also, I mean, I don't know what standard you're using. We have done also the autologous case as well. So is the good outcome for this therapy must be 50 to more than 50 to 70
20
ml.
cc,
Yeah.
Yes.
20 ml,
20 ml.
20, you're using 20
20
ml
ml.
of the hang solution and 20 ml or 30 ml of the, of the bone marrow.
Yeah, right.
And again, you see, while drawing the bone marrow, it is important how you take it. The reason is, if you are taking from the same site,
Yeah,
once the needle goes in, you don't get
Get.
enough amount of cells. So
Right.
you have to change the direction of the needle.
right.
Thank you.
Okay.
Thank you, sir.
Thank you, madam.
Is a pioneer and innovator in pediatric endoscopic surgery and stem cell transplantation. Is a professor of pediatric orthopedic surgeon from Vietnam. Professor Lim is a pioneer of using stem cell therapy for unmet diseases in children, such as cerebral palsy, due to oxygen, due to intracranial hemorrhage, neurological scale, and autism, bronchopulmonary dysplasia, and liver cirrhosis due to biliary atresia. He has published over 200 papers and was chosen Asian Scientist of the Year 2019. His presentation is recorded on the use of stem cell therapy in children. So, Professor, are you there?
It's recorded.
Okay.
First of all, I would like to express my gratitude to the organizing committee inviting me. My topic today is indications and outcomes of cell therapy for incurable disease in children. What is a stem cell? Stem cell is a single cell that can replicate and can differentiate into different type cells in our body. We can collect stem cell from different tissue, from embryo, from umbilical cord blood, from umbilical cord tissue, from bone marrow, from adipose, or from bone. Recently, cell therapy has been applied for many different diseases. And today, I would like to introduce to you our study, our research in using cell therapy for incurable disease in children. First study is bone marrow mononuclear cell transplantation for cerebral palsy due to oxygen deprivation. CP is a group of brain disorder affecting movement, posture, senses, behavior, and intellectual disorder. Prevalence is high, around 2 per 1,000 live birth. The quality of life of patient is very poor, and not only quality of life of patient, but quality of life of the whole family also is very poor. CP is burden for family and also for society. The cost to take care of person with CP very high. Estimately, around 1
1 million US dollars in US. You can see the brain damage of a patient with the cerebral palsy due to oxygen deprivation. On left side, the brain was atrophy and a lot of damage around the ventricle. You can see the clinical manifestation of a patient with the poor motor function, spastic motion, difficulties in speaking and eating. You can see the video. How we perform autologous bone marrow mononuclear cell therapy for patients with the CP. We collect bone marrow from anterior iliac crest under general anesthesia with around 8 ml per kilogram. After processing, bone marrow mononuclear cell was infused into medullary cavity. From there, they can circulate, migrate to the brain and homing there. Some data concerning the number of cells that we infuse to patients. For example, the hematopoietic stem cell around 1.7 million per kilogram and mononuclear cell 21 million per kilogram, and that is for mesenchymal stem cell. Our study reviewed that the intervention is very safe. We didn't see any severe adverse event. Some minor adverse events such as pain, vomiting, or fever, they are easy managed with the medicament or resolved spontaneously. About efficacy, you can see after cell therapy, the growth motor function improved significantly. At baseline, we use GMSM88 to measure the motor function. It was very low, but after 6 months, the GMFM increased significantly. In different domains, for example, lying, sitting, rolling, standing, all those domains, the improvement was very significant. For motion spasticity, as you observe in CP patient, the muscle tone was very high. Before cell therapy, the muscle tone was very high. After 6 months, it reduced, so it can facilitate the motor function. The second study is using bone marrow mononuclear cell for cerebral palsy related to neonatal connectors. We know some newborns suffer from jaundice after birth, and they were not detected and treated properly early, so bilirubin went to the brain and caused damage and caused cerebral palsy. We use autologous mononuclear cell therapy for CP related to neonatal connector for 25 patients. And we also noticed that after cell therapy, the improvement of motor function is very significant. This is at baseline. After 6 months and after 12 months, it increased. In different domains, such as lying, sitting, rolling, standing, walking, also increased significantly. The muscle spasticity also reduced. At baseline, were very high, but after 6 months, it reduced and continued reduced after 12 months. This is a typical patient with the spastic cerebral palsy before cell therapy and after cell therapy. We try to use autologous bone marrow mononuclear cell transplantation for cerebral palsy related to intracranial hemorrhage during newborn period. You can see that before cell therapy and after cell therapy. Before cell therapy, he could not stand up, but after cell therapy, he could walk. The other indication for bone marrow mononuclear cell transplantation is neurologic sequelae after nearly death drowning. You can see a patient with the nearly death drowning. The motor function was very poor, the condition also very poor. But after cell therapy, the motor function improved significantly. Lying, sitting, rolling, standing, walking, all domain improved significantly. You can see before cell therapy and after cell therapy, before and after, before and after, before and after. We have different for publication concerning the cell therapy for CP. The second indication for bone marrow mononuclear cell transplantation in our institute is for autism. Autism is a group of heterogeneous neurodevelopmental disorder. Prevalence is increasing. In 2014, in US, prevalence is 1 per 59 patients, 9 children. The autism has variable manifestation. For example, no social communication, no social interaction, no eye contact, delay or no language, restrictive interest, repetitive behavior. You can see a video about that. We didn't know completely about the pathophysiology of autism. However, we understood some aspects. For example, we know that in autism children, some part of brain are hypoperfused, or we can recognize overactive human reaction in the brain. They can produce a lot of harmful cytokine to neuron. We perform study using autologous bone marrow mononuclear cell for 30 patients. We use different tools to evaluate the severity and also the changes improvement after cell therapy. For example, DSM-5, adult, gas, violent, etc. For intervention, it is similar to CP patient. It means after obtaining mononuclear cell from bone marrow, we infuse them to medullary cavity and combine them with the educational intervention. After cell therapy, the improvement were very significant. We can see, for example, before cell therapy, 63% of patients without social interaction, communication. However, This reduced after 6 months, after 12 months, and especially after 18 months from 63% to 3%. Before transplantation, 7 to 6% of children without eye contact. However, it reduced after 6 months, after 12 months, and after 18 months, only 7%. The abnormal behavior also changed a lot. For example, before transplantation, 80% of children have much repetitive behavior, but after 18 months, 40%. Much restricted intellect reduced from 66% to 33%. Hyperactivity reduced from 93% to 43%. The daily skills increased a lot after cell therapy. For example, able to self-feed before transplantation, only 13.3% of children able to self-feed, but increased after 12 months and especially after 18 months. Before transplantation, only 6 to 6% of children can go to toilet, but after 12 months, it increased to 40%, and after 18 months, increased to 46.7%. The same for integrate into school. Before transplantation, 46% of children can integrate into school, but after 18 months, it increased to 73%. We observe the changes, the improvement in disease severity manifested by change.
Last part was missing. Anyway, I had a discussion with Professor Lee after he sent the recorded message. If there's any questions, I can answer on his behalf.
So for autism or cerebral palsy, for autism, so it's a multiple doses he's giving or just one?
Single dose.
Single dose. I've seen a lots of improvement in.
Yeah, because you see the autism I just mentioned earlier, about 25% are influenced genetic. So the 25% was genetic, but all his clinical trials is single dose.
So for this autism, any patient selection for a particular or just ASD, any spectrum of this?
Some of his patients were very severe. As you saw, there was no contact at all and repetitive forces. And then some patients had issues with self-injury. They used to harm themselves. So even as severe as that was included in the study.
Thank you.
Sir, in all patients he has given the dose intrathecally,
Always.
generally?
Yes. No, because it will go like spinal paraplegia, traumatic paraplegia. we give intrathecal. 2 doses intrathecal and 1 dose IV. Yes, sir.
Like what stage we can give like considering intrathecal treatment, can we try this for spastic paraplegia with spasticity in adults as well?
So that they were very badly scissoring. And after injection for that particular patient, we gave 1 dose. Then after 6 months, they came back again. But after that, the limbs were completely, not can't say completely off spastic. They were, but at least they will be able to do regular hygiene, maintenance fine. It does reduce the total spasticity. This is what the literature tells us. Yes, sir, Professor Azam, you are very quiet today. Very quiet. Usually.
So, in this study of, I don't know, Dr. Lane, Professor Lane, right? He used, I think, autologous one, not allogenic. Because right now you said that because the gene is already affected,
25% is affected with the genes. So if you find that there is a genetic influence, then you cannot use autologous. You have to go for a mashed with allogenic. Thank you for asking. No. After discussing with him, I also went into the literature and read, at least in his cases, I think they have got 110, 115 cases they have done. He told me that there was one case where there was microcephaly, and that is the reason why the child went into CP. So what they did, that they opened the sutures and then they injected, and they said there was a growth of the brain as well. That might be only one case, unless they have a larger number of cases. You cannot take that as a plus point.
So doctor, we have to go for the genetic screening before using
Autism,
the autologous.
Yes. For autism, yes.
So that is very important, as you recommended. All the physicians should tell the patient you have to go for before stem cell therapy. Thank you, sir. Yeah. We finished the second session and we have a lunch break, and we'll be back by 2 o'clock. So enjoy your lunch with more discussion. Thank you everyone here who was about the different topics of the stem cell therapy. Thank you very much.
फर्स्ट छोड़ के सेकंड में जाना, फर्स्ट छोड़ सेकंड।
It's okay now? It's okay now? Not present is okay. Now can you see? Oh, okay, sorry. So many glitches. Okay, fine. Thank you very much. And so, sorry for the delay. So now, today I'm going to talk about the stem cell therapy from bench to clinic. And this is the one of the presentation I have, which, and then we'll subsequently talk about the another presentation of the product development process. So stem cell therapy basically, if you look at the history of the cell-based therapy, so there are many things we have to understand before we go into the cell therapy. And so what are the stem cells? Basically, the stem cell, if you look at the definitions, are the highly specialized cells in the body. They are responsible to give the many type of cells. So one of the three characteristics which is responsible for the stem cells are self-renewal capability and potency and the repairs. So these three characteristics are very important for any cell to be called a stem cell. So they should have ability to self-renew. They should be able to regenerate. They should be able to repair it. They should be able to reproduce it. So all these characteristics should be there in a cells to be called a stem cell. So based on that, people have classified the stem cells on the basis of the characteristics of those stem cells. So there are totipotent stem cells, pluripotent stem cells, and multipotent stem cells. So the totipotent stem cells are those stem cells, if you look at the embryology, when after fertilizations, you have the zygote, and these zygotes consist of the both parents' genetic information. So they have all type of cells, so they call all totipotent cells. After fertilization, when cell reach to the day 5 post-fertilization, which is called as the pluripotent. So that means they have ability of these cells to form any kind of body organs. So these are the cells mostly present in the day 5 of post-fertilization stage. So this is very critical stage where you can find the pluripotent stem the stem cells, people have been studies that is present in the human eye, basically cornea stem cell, and especially they are important in the corneal regeneration. So people have published work where they can isolate the stem cell from human eye, corneal membrane, and then you can differentiate into the cornea. Same way, you have the stem cell present in the different organs and can be used for the regeneration of the eye or different kind of tissues. So here the question is that how the stem cells can be used for body regeneration and regenerative medicine. So this is the area of technology comes to the picture. In the body you have stem cells, but the body does all the repairing themselves without anybody help. Now sometimes the body doesn't produce enough or sufficient number of stem cells, so that time you need these stem cells to be reproduced in large number in order to be able to use for the transplantation and cell therapy. So here the technology comes to picture where people are using the stem cell from your human body and differentiating into the culturing and differentiating into the different type of cell outside of the human body. So this is the technology, what we call stem cell technology, where people are using stem cell culture, expansion and differentiations. And here with the help of different growth factors, you can differentiate stem cells into the different organs like neural cells, cardiac cells, blood cells. And there are a lot of, last 25 years, if you see that a lot of research publication has come which shows that stem cell can be successfully differentiated in different organs and different type of cell types. Now here the technology come into the picture where people say which type of stem cells are good for transplantation. So they say, like, based on the current research trend, that adult stem cells are more favorable because it has got not many ethical issues which has, if you look at the embryonic stem cell, which has many ethical issues, and there are issues where people have put the ban on the using human embryonic stem cell. So at the moment, most of the focus right now is driven towards the adult stem cells and how stem cells can be used to make the different type of cells. And so among them, hematopoietic stem cells are the most prominent, where you can differentiate different type of cells from the HSC and the T cell, B cells, dendritic cells, and erythrocytes. So you can see the list of cells can be differentiated. Now another example of a stem cell is the mesenchymal stem cell, which is also very important, where it can be differentiated to the bone, cartilage, and fat adipose tissues. And these are the areas which are also very critical in the current clinical applications, where you can use mesenchymal stem cells for the tissue regeneration, especially the osteoblast and chondrocytes area. Now, another area which people are also working, especially in the area of Parkinson's disease or Alzheimer's disease or a lot of neurological disease, people are also finding that neural stem cell also have potential application in this area, where you can make the neural stem cell into the neurons and oligodendrocytes and different type of astrocytes. And there are a lot of work is going on currently, which they said that at the early stage of preclinical and clinical stage, where the stem cell derived neurons can be used for replenishing the neurons in the Alzheimer and also Parkinson's patient. Now there is another type of stem cell which comes to the picture, where they find that if the body doesn't produce enough stem cells, so now they are using the induced pluripotent stem cells, where you can make the somatic cells behave like a pluripotent stem cell using the transcription factor technology. And the work which has led to the discovery of this IFSC and Shani Nama, Japanese scientist, who got the Nobel Prize in this stem cell, where he can claim that the somatic cells can be make them into the pluripotent stem cell, and then you don't have to work on the embryonic stem cell. So this is another area people are working, but still in the early stage of development. So considering this thing, the stem cell has a variety of applications, including almost all the body organs can be repaired at the moment, and you see that, and various different kind of applications are there. differentiated into the kind of functional cardiomyocytes. So this very promising results which shows that how cells can be not only make them morphologically look like, but also functionally look like this thing. Now there are two questions for the people, like which part of the stem cells are good for the transplantation. They say like allogenic and the autologous transplantation. So the two things are happening, like, and both are important, because I know autologous transplantations means that you're taking the cell from the same patient and transplanting back to the patient. So like you are using same cell from the same patient. So advantage is that you don't have to be worried about the immunorejection, and there will be less rejection. But in the case of allogenic, yes, you're taking the cell from other patient and transplanting back to the patient. So here the chances of immunorejection will come, and the success rate is also showing that less compared to the autologous transplantation. So the current research shows that autologous transplantation is a very advanced stage where you can take the cell from the patient and regrow in the laboratories, and then transplant back to the patient without worrying about ethical issues, without worrying about the immunorejection and histocompatibility. So all those things are very critical for the clinical trial. So there are different benefits of that. So we'll look at some of the clinical trials are happening in the mesenchymal stem cells. For example, if you look at currently around the world, the different kind of clinical trials using the stem cell derived from mesenchymal area, like musculoskeletal area, which is the highest number of clinical trials are happening. Then cardiac, then GVTH, then inflammatory, neurological, liver, diabetes, and then other kind of things. So you can see that the variety of organs have been been used where clinical trials are currently used for the regeneration. If you look at the current market, because this is a very important thing in any technology, that you have to know the financial aspects of any technology. How much stem cells are there? What is the market? Because you cannot just make things and then it becomes difficult for the people to make in financial or commercial way. So if you look at the US stem cell market, which is predicted by 2030, like 2020 it was $3.5 billion. Now going to at the moment it's like almost like $5.6 billion, and by 2030 it is expected to reach by almost $30 billion. So this is a very promising area. You can see that how the stem cell technology is being used at this thing. Among this thing, you see adult stem cells are highly giving the highly promising results. You see that among them compared to embryonic stem cells and iPSC, so the commercial aspect is very high in the adult stem cells. So this is the area because there is a lot of benefits are there using adult stem cells. And if you see the global stem cell market at the moment compared with the allogenic and autologous, so you can see that at the moment you have the 2022 $11 billion, and around 2032 it will reach to $44 billion. So this is the predicted market which is keep increasing, and showing that how stem cells is commercially viable projects. Now, among the different kinds of stem cell, global allogenic stem cell is also one area which is also being highlighted very well. There you can see that the stem cell, especially from bone marrow, peripheral blood cell, umbilical cord blood stem cell, adipose tissues. These are the sources of stem cells are being used for the allogenic stem cells. So there is a market for that, and mostly used in the skeletal, musculoskeletal disease, cardiovascular disease, and autoimmune disease, especially also in oncology and beauty. Now, if you look at the mesenchymal stem cells, also showing some very important growth in the mesenchymal stem cells. We can see, especially the autologous and allogeneic. So both area people are targeting, and the source are basically bone marrow, adipose, cord blood, peripheral blood, and also dental area. Also, people are using this. This. One of the highlights of this thing is the cardiology, where the stem cells are being used heavily, and especially in the usually characterized and can be checked whether these can be used for medical function. So if you look at the stem cell clinical trial around the world, so you see that at the moment United States are mostly 40% clinical trials are happening in the United States. Iran also coming up very heavily in this, 20% in Iran. And in India, if you look at 3% clinical trials are happening. So it's like very upcoming field and where people are investing and bringing more such kind of initiatives in developing countries where it can be developed. And among the different clinical trials, so look at the different type of thing where people are disease point of view. Like nervous is a highly one of the most important areas people are targeting with neurological disease, then cardiovascular disease and bone, also important, bone cartilage, autoimmune disease, liver and this thing. And so you can see that the where the trends are showing and how people are investing in this area. Now this is basically one area which I understand that to develop the facility in order to understand, because you have to know this is a technology, it has a product, so you require to know, like as we make the drug or pharmaceutical company make the drug, same way the cell therapy company makes the cell. So it has followed the similar kind of guidelines, like which requires like cell from the patient, then it goes to the center. It can be differentiated, it can be characterized, it can show that it can make the different type of cells. Then it has been purified and then finally converted to the products and taken to the hospital for the transplantation. So these are like real guidelines where you can use it for your understanding. So this is the basic thing about how stem cell therapy are being placed in the world at the moment, where we're heading right now. And this is a very important area to invest and to not only for the business point of view, also like patient point of view, to provide the better solution for the lot of disease which doesn't have medicine at the moment. Like some problem, the side effects, like some problem with the drug resistance. So all those things can be overcome with this stem cell based therapy. Thank you. So do you have a question answer session here?
Any doubts? Anyone? Oh, we move
Shall
on
we
to
proceed to another?
Yes, we move on to the next session. So the next session is going to be Professor Haifa Al-Turki is the Professor of Obstetrics and Gynecology at College of Medicine, Imam Abdul Rahman bin Faisal University, Dammam, Saudi Arabia. She has double PhD in assisted reproductive and endoscopic surgery from Brussels and Antwerp, Belgium. She had her fellowship at the Center for Reproductive Medicine, where treatment of infertility in men as well as women was carried out. The center has pioneered advances in reproductive techniques and their application, hereby achieving a worldwide reputation. In its first 25 years, over 15,000 babies have been delivered following their parents' treatment at this center. So in this session, we are going to hear from her about the benefits of stem cell therapy in infertility. Over to you, ma'am.
Can you hear me?
Hello. Yeah, so what I should do? Okay.
basically, the results showed that ovarian structure and function could be restored by bone marrow stromal cells, and this one was published in 2018 trial. With this background about the mesenchymal stem cells, we are going to speak more about the role in assisted reproductive technology. As you know, worldwide and according to the WHO, about 15 to 20% of all couples who are trying to conceive, they have difficulty in reaching the pregnancy. Unfortunately, this infertility rate is going higher up. we conducted a study here in Saudi Arabia about a few years ago, where it showed about 19.7% of couples having difficulty in getting pregnant. And we know that worldwide the fertility is declining. There are numerous factors which play a role, aging of the female partner till they start having the family, a lot of other hazards and pollution playing a role. Causes of infertility are different, either be a female, male, or either both infertility or even unexplained infertility. So mesenchymal stem cells show strong immune-emotional effects, and that will reduce the apoptosis of the granulosa cell in the ovaries. Accordingly, it can recover and help to recover the ovarian function. And with the recovery of the ovarian function, we will have a better level or improvement of the sex hormones. We are speaking about estradiol, progestin, as well as anti-mullerian hormone, which is the reserve of the ovaries. And accordingly, the fertility can be restored. It was shown in animal studies that the bone marrow stromal cells were able to restore the ovarian damaged tissue by chemotherapy and recovered fertility accordingly. There is a study is going on now, clinical trials, where we are experimenting on the female and male rat, where we are giving chemotherapy and then followed by stem cells, injection mesenchymal stem cells. The study is still going on. We hope that soon we will share with you the results, inshallah. Several studies reported improvement of the ovarian function as well as reaching pregnancies in ladies with a premature ovarian failure because of the iatrogenic use of chemotherapy and total radiation, where the mesenchymal stem cells therapy derived from bone marrow transplantation are injected or being part of this treatment. Implantation of autologous bone marrow stromal cells to treat also the endometrial injury. So it's not only playing a role on the ovarian stroma or ovarian tissue, but it also plays a role in the endometrial tissue, where a lot of infertility is happening due to an injured endometrium or a very thin endometrium. So it can be used in cases of Asherman syndrome, where there are intrauterine adhesions. It can be used in cases of the recurrent implantation failure due to a very thin endometrium. There was a trial which was published in the Journal of Human Reproduction Science in 2018. This lady was about 45 years old, premenopausal, with low AMH. Her ultrasound was showing a normal uterus with one antral follicle in each ovary. And this lady was hoping to go for assisted reproduction because she was unhappy to go for a donation program. And we have to remember that oocytes donation program is not widely accepted everywhere. It is a very well going on program worldwide, but there are a lot of restrictions in a lot of places due to cultural and religious background. Being in the Middle East, i.e. mainly in the Gulf region, Saudi Arabia, we do have no oocytes donation program. And this will lead to the importance of having other modalities of treatment to help both ladies. This lady was injected with autologous bone marrow from the mesenchymal stem cells. After about 3 months, her AMH started improving, and accordingly, her FS started dropping. She was stimulated, and on the day of the ova pickup, 3 oocytes collected, were mature, and one of them fertilized, transferred one embryo, and an interesting uterine pregnancy seen with cardiac activity. She had an IBT test at the gestation typing, and she delivered a healthy baby via cesarean section at term. So in our trial also, we had 2 patients who opted to go for stem cell, mesenchymal stem cell injections. Those ladies, both of them were having a very poor ovarian reserves, and they were not responding to gonadotropin injections. So both of them were injected with autologous bone marrow derived mesenchymal cells. One patient underwent the program. She started the stimulation, and on the day of the trigger, she was having 5 oocytes. On the day of the retrieval, we had 3 mature eggs, all of them injected, and she formed 3 embryos. One of them reached almost to day 4. We were wishing for day 5, but unfortunately didn't transfer due to a lower quality of the embryo. This patient was always not responding before to any stimulation. If we will look to the other side where we spoke about the female infertility, let's look on the male side. It was found or reported that male factors is about 40 to 60% of all the couples suffering from infertility. And it is known and reported that male factor is increasing worldwide. It can be the oligospermia or azoospermia, but here we are going to concentrate in azoospermic patients. And as you know, the azoospermia, we have the obstructive and non-obstructive azoospermia, where the non-obstructive azoospermia is the main issue to be discussed. And it constitutes about 10 to 15% of all the male infertility, and reaching up to 60% on those who are azoospermic. A non-randomized trial, which was published in 2022, it was an open-label phase 1 clinical trial, where 19 participants undergoing a non-obstructive azoospermia had been treated with autologous bone marrow mesenchymal stem cells. After the bone marrow aspiration and cultured, they have an injection of those cells in the testicular tissue. As you see here on the top slides, the bone marrow aspirated, cultured in the lab as mesenchymal stem cells, and then the mesenchymal stem cells were injected in the testicular tissues. Patients were evaluated. Of course, those people, most of them, they went even before to a microtasy, where it was completely negative. Patients were evaluated for semen parameters and as well as their hormonal profile. So like we are speaking about the FSH, total testosterone, LH, inhibin B, prolactin, before and 6 months after the injection of the mesenchymal stem cells. As you can see here in the graph, the testosterone level starts increasing after the injection, and the FSH started dropping after injection of the mesenchymal stem cells. LH also starts dropping after the injection, and inhibin B starts improving after the injection of the mesenchymal stem cells. Prolactin levels started dropping after the injection, and the interesting thing, if you will look on the right-hand side of the slide, you can see that those people who were completely azoospermic, there was 0 sperms on their semen analysis, they start to show some sperms on their semen parameters. So about 4 patients, we are speaking about 21% of those people who underwent this injection 6 months after treatment, there was spermatozoa. And here we need to have a time, you have to bear with the patient, because as you know, the cycles of the spermatogenesis needs about 72 days or more to be regenerated. So definitely we are not expecting results earlier. This study confirmed that the autologous bone marrow mesenchymal stem cell is safe, effective in the treatment of non-obstructive azoospermia. So if we will look about the PRP, and we know that a lot of fertility people are trying to inject PRP. There was a study which was published late summer last year in Fertility Sterility, where it showed that PRP may help some of the people, but it's not significantly helpful, and it cannot really be advised as a modality of a treatment to those people because of the unknown effect and not much benefit seen. 71 women, this was published in 2022, 71 women were included, where 21 were diagnosed with the primary ovarian insufficiency according to the ISHRI recommendation. And 50 of them were diagnosed as poor responders. They had PRP injection and did not appear to increase the live birth rate or clinical pregnancy rates in those poor responders or those who are suffering from primary ovarian insufficiency. We know that there are complications of PRP. We are speaking about possibility of bleeding, possibility of tissue damage, infection, as well as injury. So the clinical application of the stem cell therapy became more popular to treat patients with primary ovarian insufficiency or even premature ovarian failure, as well as in non-obstructive azoospermia. The oocytes and granulosa cells regeneration, along with re-establishment of the hormone and cytokines profile supporting. Stem cell therapy helps in follicular development and may be involved in the improvement of both the ovarian function and damaged ovarian function and restore fertility, either due to iatrogenic effect of the chemotherapy or due to ovarian response. Okay, that's all. Thank you.
Thank you so much, Professor.
I cannot hear you. I don't know whether you are still hearing me or not.
We can hear you. Can you hear us? Yes, yes.
Hello?
Good afternoon, ma'am. This side, Dr. Lipi is actually working in
I will. Yeah, but I cannot hear anything, so I didn't know whether you can still hear me.
I'll give the phone once again. I'll give the phone.
Hello, ma'am.
Yes, hi. So I'm sorry, I'm connecting now because I cannot hear you via the Zoom, so I'm connecting on the FaceTime and Zoom, so maybe the others can hear me, but I can't hear you. So go ahead, please.
So I have a question about the efficacy-wise PRP or bone marrow MSC, because I have done the cases with the gynecologist is for the PRP, and it's 50% patient is they recover. I mean, they say endometrial thickness was increased with the PRP. So what's your experience about PRP versus bone marrow MSCs?
Okay, so to be honest with you, we don't have that much large experience. You have to know that the PRP and stem cells is not yet approved here in Saudi Arabia by the Saudi FDA. So not everyone is doing that, but there are trials on the PRP if we are speaking about our local experience. So people are using the PRP for the ovarian function as well as the endometrial tissue. And as we said, it's going with the general publication worldwide. Yes, some of the patients may get benefit, may improve, yet a lot of patients may not get any benefit. And it was shown that the PRP is working better with the younger age group and simple injury of, or a simple problem with the endometrium, where the mesenchymal cells showing a better outcome in a real ovarian failure, or because there are even some trials on postmenopausal ladies. If we will look on the male factor, unfortunately the PRP did not work on those men. And again, with the PRP, there is no real, and still on the stem cells, also we need to go for more research. We need to know how much we have to inject, when we have to inject, and all of those things. Because even with the PRP trial, people are trying different ways and different scenarios.
Yeah, that means the procedural difference, how you inject, that's the thing.
And when to inject, absolutely.
And what's the age limit for the female to go for this therapy for ovarian failure patients?
Yeah, because here we don't have a large number, and also the publication does not have a large number, but as you saw here, That's why I presented the 45 years old, which considered to be one of the extreme age. But as you are younger in age group or tried in younger age group patients, especially those patients with the primary ovarian insufficiency, the results will be much better as going with the elderly patients.
Thank you very much.
Most welcome. Dr. Azam, nice seeing you. How are you doing? How is Dr. Azam and the kid? So happy to see you.
Thank you. So it was a wonderful presentation.
Thank you. Appreciate it. Thank you very much. Appreciate it. And we hope, inshallah, we will see each other in Hyderabad soon.
Thank you very much. Have a good day.
Thank you, Prof. Thank you, everyone, and wishing you a lovely day all. Thank you.
Coming to the next guest speaker, we've already been introduced to her. Dr. Lipi Singh has a PhD in experimental medicine from Chandigarh and fellowship from California Institute of Regenerative Medicine. She's the Vice President of Advanced Cell Group, Noida. She has 18 years of experience in stem cell technology. She has numerous publications in national and international journals. In India, there are estimated 77 million people. 25 million are pre-diabetics who are at a higher risk of developing diabetes in the near future. There is no permanent cure for this disease, and stem cell therapy is the hope. Let us hear on this subject from Dr. Lipi Singh.
Thank you
Welcome.
very much. Good afternoon, everyone here. I would like to thank, first of all, the organizing committee member who allowed me to speak or discuss about the diabetes, which is the global pandemic. So let's start. Before that, a little bit I will speak because I was in a beta cell transplantation in 2000. I was doing my postdoctorate and part of the clinical trial at that time. So I will share some experience about the beta cells, and up to now, the exosome technology, which can help to cure. It's not saying reversal cure of diabetes, the possibility is still there. So we have, this stem cell have a potential to do that. Slides, please. So that's why I have written there is a hype to hope. So before stem cell therapy, there is no hope. Now there is a hope to cure diabetes. So I just give the introduction here that is about 500 million diabetes patients about 29 years worldwide in 2017. Now it is increasing up to 700 million by 2045. And India alone, the number stands about 77 billion. So, and also adolescents or the children having 0 to 19 years old with type 1 diabetes are going to increase 1 billion. So you can see the prevalence, how much worldwide. Next. So this is the data I just pulled out from the literature. That is, we have going to, this according to the CDC, 500 million people are living with the diabetes globally. Actually, I cannot see the slides here.
You want to come now?
Better. So we are saying we are best in healthcare system. So what's wrong? You have the data about 500 million people are living with the diabetes globally. The question arises why and how we have developed this diabetes. Our system, healthcare system was never designed to cure chronic disease like diabetes, which projected to be increased 700 million in the next 20 years. That's a huge number. And now system here is, which is in the healthcare, is we can do it, manage and suppress the system, but never cure. Next, please. So we have to understand there is a link between chronic inflammation and type 2 diabetes that we have to explore. Because now healthcare only managing the symptom of the diabetes, not for prevention or cure. Because effectiveness of anti-diabetic drugs such as metformin and GLP again is hardly 30%. And current set intervention focused on managing and suppressing the high glycemic hemoglobin, that HbA1c, right? So diabetes is the last stage of metabolic syndrome. It starts 15 years earlier. First, fasting insulin goes up, and then glucose goes up, and then finally HbA1c goes up, what we see in the report. Next. So why the need of stem cell-based therapy? This is the reason. Insulin, an external glycolytic agent, can often used to control high blood glucose, but they cannot accurately mimic the secretion of endogenic insulin and may cause reactive hyperglycemia. So pancreas or islet transplant is another alternative, but quickly control the hyperglycemia and eliminate the need of exogenous insulin supplementation. The drawbacks here, because there is a morbidity with the major surgery, limit graft survival, and availability of donor pancreas, and lifelong immunosuppressive medicine we have to take. Go back. So there is also another effect, the insulin price is also increasing every year, and you can see the data. And that's the reason stem cell derived or beta cells, and this is required, because beta cell therapy or transplantation has some limit donor availability. Next. So we are made up of cells, not the drug, as everybody knows that. And in the beginning, there is stem cell. It's the origin of organism life. So we have to believe on stem cells. These are the basic, already gone through with several lectures, so I'm not escaping all this. But you know the stem cell property that is very important, self-renewal and the differentiation. These two properties are very important for the stem cells. Next. And this is, everybody's know that human embryogenesis. There is the different stages. The zygote, we have another is the totipotent cells. And next after day 6, there is a formation of inner cell mass and blastocyst formation, and we call it the culture pluripotent stem cells. Next. So we have to understand totipotent, pluripotent, and multipotent cell difference. So you say totipotent cell, that is cell 4-cell embryo, and that is differentiated in any part of the cell tissues. But there is the formation of teratoma, as you already got through the several lectures. Pluripotent is the another kind of stem cells that is also give the 3 germ layers: ectoderm, derm, and endoderms, mesoderms. And then is the multipotent stem cells. It is the more lineage specific. So these are basic difference. So you have to understand the difference between all these. Next. So one of the induced pluripotent stem cells already, we have learned more about that. Next. So focus on the mesenchymal stem cells. This can be minimal motivative, xeno-free, or hypoxic. The difference basic. Minimal, we are not going to treat or harvest the culture outside the body for a longer time. Xeno-free, not using any animal culture of the stem cells. And hypoxic, that is keeping the condition like less than 2 to 4% loss. So it will be more, you say, super cells kind of. So these are the basic difference of mesenchymal. This is customized according to protocol. Next. So already Dr. Mego talked about the mesenchymal stem cell. I told you that basic, you have to understand the two important things: self-renewal and the differentiation process. That must cell contain these properties. And this is the explant culture showing the stem cells that is originated from the umbilical cord. This is Wharton jelly. We are working more on the Wharton jelly mesenchymal stem cells because we have found that bone marrow adipose, we harvest for the patients very less amount, and the time of culture is more. So we more focus on the Wharton jelly easy available because this is a discarded material, and because expansion is easy and we get the more numbers. Next. So International Society for Cellular Therapy has decided MSC should have these properties like plastic adherence. It must be adhered to the surface, and they express the positive and negative marker, already talked to Dr. Memo. And another important thing, during the culture, what happened, there is a telomerase activities, the telomerase shortening, so there is a loss of activity. So we have to check the chromosomal analysis must be done before infusing the cells. So this is very important. And also, passaging is important during culture. Maximum allow is P3, P2 and P3 passage. Next. So, we won't talk about the beta cell replacement therapy. This is done in 2000. There is Edmund protocol, and I have experience with that because the part of clinical trial there during my postdoctoral research on this. And then mesenchymal, and then next to exosome technology. Next, please. This is the beta cell transplant. What we are following the Edmund protocol. It is published in 2000. And what they're doing, this islets was isolated from the cadaveric donor culture and then injected in the portal vein patients. And there's a remarkable, we have found that is efficacy-wise because the type 1 diabetes especially treated before, and they had developed, they did about 70% patient requiring no insulin injection after 2 years. This is the great, you say achievement during this beta cell transplant in 2000, but later we have found that there is some limitation. First, we cannot get the adequate number of functional islet cells, and also, we need a cadaveric donor of this pancreas. That is also a limitation. And there is a long-term necessity of immunosuppressant that is required. So what's next? There is advantage with the stem cell technology. In this, we initiated with the early, that is a induced pluripotent stem cells. Stem cells that differentiated into beta cell, it's a lab culture thing. And then this is transplanted. Next. Go back. And this is done by first Dr. Melton lab in Harvard Stem Cell Institute. He is the pioneer of this. Next. So there is a protocol for induced pluripotent stem cell to the beta cells. These are fixed protocols. And we have to see the functionality after getting the beta cells, whether it's glucose sensitive or not. Next. So you can see here, the induced pluripotent stem cell generated from the patient's somatic cell can be differentiated into pancreatic progenitor cells that mature in vivo, which is glucose responsive. This is very important part. And then transplanted in diabetic patient. Next. Is the institute, I think everybody know that US Beta site is working on the same line of things, and it is it's a regenerative medicine company, and they developed pluripotent stem cell PEG01 pancreatic islet progenitor cells, which is implanted in and which is durable and retrievable cell delivery devices. So engrafted, also already clinical trial in type 1 diabetes. Next. So this is the device which is having the induced pluripotent stem cells, that is pancreatic progenitor cells, which is the device which is protect the stem, protect from the immunoreactions. So this is already in the clinical trial. Maybe they have phase 1 clinical trial and they do. So definitely in coming years, we have something like this can be implanted for the type 1 diabetes. Next. So we have done the study, our lab at one cell, on transplantation of autologous stem cells, especially bone marrow. We are earlier working with bone marrow in type 2 diabetes. And we have found a good result, very optimistic for this treatment. And you can see fasting glucose, we have followed up with the fasting plasma glucose, plasma insulin at HbA1c C-peptide level up to 12 months. And you can see here, there is a 50% reduction in insulin dependency. And we have the age of 51, average age, both female, male, and duration of pancreas is 5 years, we have taken, not 10 years. So it's 5 years, history of diabetes. So early is important when you go for the stem cell. And after stem cell therapy, 18% patients were observed. That is our primary objective of the study fulfilled, that is reduction of insulin dependency by 50%. Right? So some of the rest non-responder also, but maximum we have found a good result. Next. Just saying, going through the whole previous history or review, and already talk about the next beta site for type 1 disease. These are already clinical trial type, phase 2 clinical trial. Maybe in coming years we come up with this device. Next. These are all clinical trials showing that study is going on, and never seen that any reported any adverse effects. So it's more safe, and efficacy is varied definitely. It depends on many factors. Next. So they have used the bone marrow, HSC, MSC, everything, and the infusion mode is always IV in all clinical trials so far. Next. So these are the outcome of stem cell therapy. So bone marrow metabolic stem cell therapy, about 12 months there is significant increase in the C-peptide and the HbA1c load up. So you see that the positive outcome of the clinical trial so far in type 1 diabetes. Next. And this, I want to read that because it's very important, because bone marrow HSC transplanted exogenous insulin requirement decreased significantly during the follow-up period. And about 60% achieved the exogenous insulin independence. So you can see clinical trial also showing the positive outcome. So all these overall, there is a decrease in exogenous insulin requirement, which is a big achievement with the stem cell therapy. So far, no chronic infection or has been reported so far. So it's safe procedure. Next. About the type 2 diabetes and clinical trial. Next. You also see that here several trials are done, and there is definitely the efficacy of bone marrow MNC after 12 months of therapy. The HbA1c sometimes not showing significant improvement, but bone marrow MSC showing HbA1c lower down. So in this clinical trial showing that bone marrow MSC is more efficient for the type 2 diabetes. Next. So here also the insulin requirement goes down with these follow-up about 12 months. And these are all data from the published data. So, and also daily insulin doses reduced by 15 to 50% in these trials, in most of the patients. Next. So far, never reported any MSC transplant, any adverse side effects, severe, but little bit mild and moderate. And so it's the same, bone marrow MNC or bone marrow HSC is good for type 1 diabetes, but for type 2 diabetes, bone marrow MSC is more efficient. Next. So these are the clinical data. They have gone for MSC, bone marrow MNC, lots of data showing that. Next. So conclusion is that bone marrow MSCA and in this is more efficient in type 2 diabetes because there is a C-peptide increase and HbA1c was down. For type 1 diabetes, it is reported that bone marrow MNC is better. Next. So this is very important part, how we inject the stem cell in the case of diabetes. So in our case, what we have done studies that we have infused into suprapancreatic artery. This is very important where you are injecting. Homing of stem cell is very important in pancreas. Some studies showing splenic artery, some showing intravenous route. But the most efficient, that is superior pancreatic artery infusion. This is important while doing treatment of stem cell, treatment of diabetes through stem cells. Next. So route of administration is important for efficacy of stem cell therapy. This is very important. So we have seen lots of clinical trials through IV delivery, but we have done with the specific target delivery, that is through arterial, and got good results. Next. And the other study also showing that target route of showing delivery of stem cell showing a significant reduction of insulin requirement at the end of 6 months. So this part is very important. Simple IVF will not work. So we have to go for little bit target therapy. Next. So next is the exosome technologies coming up with the stem cell. I just prepared a video. You just say what are the exosomes. Is coming? Exosomes form. So cell membranes through exocytosis coming out, endosomes, and there is a filling of protein, lipid, and microRNA or messenger RNA. This is the part of exosomes. This is cell-free system. After this become exosomes, and then going to the target one, the recipient one, where it show its activity, because it's help itself to cell communication. You see this too. And this contain lots of growth factors, help in angiogenesis and wound healing, and help in basically the cell communication between donor and next. So exosomes, everybody knows that is extravesical part of the cells, but not having these cells. It's a cell-free system, no DNA, so no genetic manipulations, only mRNA, which is help in communication. We also pass through the blood-brain barrier, so IV injection will do. Some doctors plan to do target, but no need of it because it can cross the blood-brain barrier in the case of if you go for some indication in neuro cases. Next. I think this is part of this protein because I told you we have to do characterizations, the lab work. That's all. Next. And just want to do type 1 diabetes exosomes are also in the clinical trial. So one of the paper they show that this is good result with the exosomes. So we are very optimistic to use in type 1 diabetes exosomes. So basically mechanism action is the immunomodulatory and regenerative effect. So this is the same as the stem cells. And also important type 2 diabetes, as they say, that diet is very important because there is a link between the chronic inflammation and type 2 diabetes. So if you are given even the stem cell therapy, diet is not maintained, that stem cell therapy won't work. So both combination is very much required because there is the inflammation when you eat, lots of inflammation in your body that you have to do inside. Next. Summary, I think diabetes is a chronic metabolic disease, high morbidity and mortality. And in type 2 diabetes, HbA1c and insulin requirement decrease significantly after MSC transplant. So I told you the bone marrow MHC, organ MHC, more efficient in type 2 diabetes, while in type 1 diabetes, bone marrow MHC or bone marrow HSC is important. And so far, stem cell therapy is relatively safe and effective methods in case of treatment diabetes. So, and we have seen the favorable results so far in clinical trial and published articles. Next, the last slide. So, you see that already the same thing, bone marrow HS is good for the type 1 diabetes and type 2 diabetes. Definitely bone marrow MSC is more efficient. This is the take-home message you should want to use. Be careful what you are using for the therapy. We are looking for collaboration. If you need, we can help you with that. Next. Thank you. We are Bansal in Noida, Uttar Pradesh. Thank you very much. If you have any questions.
I have one question. No. I know you're talking about the exosomes.
Yes,
The lifespan of exosome is short-lived. You see, once the vesicles are ruptured at the site, they are absorbed and excreted out.
Yes.
Whereas when you talk about the terminal cells, their lifespan is 120 days.
No, sir, we cannot say exosome lifespan is low. Lower than the cells. This exosomes is nothing but the protein.
Yeah, I know. See, once a protein comes under the circulation, it will be...
So it goes to where required.
Yeah, okay. Wherever it reaches there, and it will be absorbed very quickly into the...
Yes, right,
yeah.
sir, but it's a communicative. It communicates what is required there. Once communicated, nothing has to...
Yeah, I know. But at the same time, when you are injecting the stem cell, like osteoblast, if I inject, the lifespan of osteoblast is 120 days, and it will continue to do whatever it's supposed to do. That's, I'm just asking a...
So, osteoblast you're talking about
Or
was...
even chondrocyte.
Chondrocytes. So, lifespan is there, but what's the exosome is to see what its duty. It has to go and tell the cell what to do.
Yeah.
So that's all.
That's it.
Yeah.
The same thing happens with the...
So these osteoblasts might be having it communicating with the cells where you are injecting. The same way, the function will be
But they
definitely...
will be, communication will be repeatedly for remaining 120 days rather than only 1 day from the exosome.
No, sir, cells.
Alimsa, what do you think?
No, actually, you are both on the same page. The only thing is that, see, indication here is the, yeah, some...
No. I'm not going to answer, I'm going to ask.
So, basically, exosome is very ideal in case of the Parkinson's because there is a problem of the blood-brain barrier. Otherwise, the point which you are making is valid point because when you are getting a continuous engrafted cell which will continuously
inject it.
extracted from the osteoblast, not from the MHC.
Yeah, the same thing, sir. See,
Once we did that, we found that the bone formation between the exosomes and osteoblasts was way, way different. Osteoblasts had a very robust bone formation compared to exosomes. Exosomes and mesenchymal stem cell were the same linear picture, but the osteoblasts were too high.
so here also the mechanism here action is that osteoblast you are giving. Definitely he has the secretory molecules. These secretory molecules nothing but the exosomes. Where also.
But you see, this is one concept.
Yeah.
The second concept is, you see the cell wall itself. The cell wall itself has got a lot of protein material.
You're right.
If you take a osteoblast or a chondrocyte, the exosomes which you are extracting from the cytoplasm.
Right.
Compared to where actually the cell wall has got some function. Yes, sir.
This week I have completed very important data on this. What I did is, actually what I did is, I had a lot of questions to myself, this type of questions. And yesterday again I had repeated. I cultured the mesenchymal stem cells and differentiated to neurocyte. Okay. And after differentiating neurocyte, I took out the only media, not the cells. Then I concentrated it. I went for the high throughput proteome analysis. I got around and hundreds of the protein. But the point, just trying to correlate what you are saying, then I asked my student to only segregate the protein factors which are involved in the neurological regeneration. I got around 300 neurological factors. Okay. There are different, as you're saying, when you talk about the cell membrane, all receptor, ligands, protein, everything is there. The point what sir is saying is valid point. That means you are providing the receptors, ligands, everything which they can communicate. Okay. So now, yesterday afternoon, I talked to one company and I told that when I am concentrating, I am getting 10 ml of my media. A 10 ml media I cannot inject in your orthopedic cases. Now, I need to lyophilize that and then inject it. So, exactly the point in the stem cell therapy, all these are the valid discussions. But what happens if when it goes to one particular doctor, he has his own application, he has his own limitation. When it comes to ortho, these are all different types of things. When you talk about the factors, when you talk about the transcription factor, when you talk about these exosomes. So I thank you for your giving us the good insight of the discussion.
So if I remember my physiology,
yes, sir,
many years ago, we were told the cells, they talk from the cell membrane to cell membrane.
I will tell you. More than 100 nanometers. When you talk about the exosome, they are less than 100. There is a clear classification. I was about to present one of my students who is working in NIH right now. He has made an induced pluripotent cell, which is CRISPR made and synthesizing only one particular type of mRNA for some eye disease. So it's something like the things which are moved ahead. It is beyond the science is moving so fast, and the knowledge. We don't know what exactly is where we are. Yeah.
So we are HEPCO for what's going on. Yeah. So we are HEPCO for
the only thing which we thought, as we said, we are discussing here, me and our team, we sat down, we say, how come the effect of exosome was lower than the terminal cell? This was the concept we discussed so many things and we came to one conclusion. We came to the conclusion might be because we injected only 106 micro ml into the site. So might be our dose was so low, if we have increased the dose, might be the...
1 micron dose of the exosomes
Yeah.
is quite high, I tell you.
Thank you very much.
So how many billion exosomes, sir, when you injected in 1 microliter you are talking about? The billion exosome quantity, how much they give?
I think it was 0.5
0.5 ml contain how many exosomes?
What the dose given was 106 micro ml of exosome.
So you have to ask them, please, because need the quantity the exosomes. 1 ml contain lots of things other than.
When we discussed, for me, I was thinking, I still believe that the exosome is cleaner than the term itself, but the proof is not coming. So I was thinking myself, might be the dose we cannot give properly.
I will give my one last, you will be confused listening me, but I will certainly. When we start moving from the acute to chronic, there was one particular question we asked ourselves. In a cirrhosis, the liver is shrunken, vessels are collapsed. But how to and what type of cell has to be given to in this particular condition in a liver cirrhosis where you cannot touch the portal vein, where you cannot do anything, the moment you do it, it will bleed. Like hepatic artery which you are saying. There were two questions. Putting cell or viable thing, when you put a chemical drug, you don't have any problem at all, first of all. But when you are putting exosome or anything biological material, you cannot put through the vertical vein, that is, wrote it down. You cannot put it through the vein. You have to use only arterial circulation only. Why? Because there will be lot of abuse in the veins, that will itself will kill the biological cell or exosome. And that is the reason in our case when we start liver cirrhosis, we took the help of intervention, we went through the hepatic artery only. Now, I cannot put a 20 micron cell of 30 million cell in that liver which is totally shrunken now. So what we did, we went down and out of that we sorted only few cells. I did the electron microscopy which were only 3 micron in cell, but beauty is that the moment they go, they start proliferating. And they should, so all these clinical applications, when we move from the lab to the particular clinical application, there is an interface. And then the particular indication comes from the treating doctor. And they say, no, you cannot do this, you have to do this. So we took, so that is, yeah, please.
No, it's okay. I'm listening. I told you I forgot the question.
Yeah.
Professor Sadat has more questions these days.
No, we have to.
No, actually, right.
Yeah.
So it was a good presentation, and from the morning I was thinking that in all the stem cells, we know that mesenchymal stem cells has got source in the bone marrow, in the adipose tissue, or in the fetal tissue. In most of the clinical trials, what we are doing is we are taking from the bone marrow. For example, in your case of this one, pancreas and diabetes, is adipose tissue derived mesenchymal stem cells not good enough? And if not, then why?
No, we just say that it's not good because we have done the both things, bone marrow alone, bone marrow plus adipose bone, but we have seen the efficacy more in bone marrow derived MSCs. So that's the reason we couldn't find out if your combination of two giving even not effective than the bone marrow itself.
Right. So it has been confirmed. I think categorically I can say that large studies have shown, coming from US and Europe, that the bone marrow MSCs are far superior than the adipose tissue. The quantity is very high in adipose tissue, the quality is really bad. Compared to the, I can give you plenty of, it's not exactly like that perhaps. No,
it's not exactly perhaps
like. We cannot say that adipose quality is.
I will give literature. You bit with literacy, not me. So, no. What I read is that the mesenchymal, you can also answer actually. This is my genuine concern, that the mesenchymal stem cells, when they proliferate, they are more osteoblastic, and maybe they are good for the bone pathologies like AVN and other things. When it comes to cartilage regeneration, it is the adipose type derived mesenchymal stem cells which are perhaps better. So we cannot say one is superior to the other. It is the indication which matters.
No. It is 100% sure that in IV rather than giving in the.
Sir, if MSC you are injecting, you're going to the whole body circulation.
No, there is another reason for it. The size of the MSC is so big that 50% of that will be stopped in the pulmonary capillaries, and only whatever is released is the exosomes.
Yes.
See, that's the reason why we were trying to work on exosome. Yes, we were trying to work on the exosome. We didn't find exosomes that better. This is what our.
So I think more study needs to be done. So one single study cannot decide that if it's not better than
Dasasa, last one, because he has raised one important point. There was a review article in there were two societies in the world, let me just tell you, which control the stem cell complete classification. That is called International Stem Cell Therapy, ISCT, and so there is a second committee, we call it Stem Cell International Stem Cell Research. So one time Kaplan is a scientist who first time who discovered the mesenchymal stem cell. Recently 2017 he wrote an article and said that when I discovered the mesenchymal stem cell, I thought of making is a medicinal cell, but people will react to it, I made it in a stromal cell. The ultimate message right now, in terms of the confusion, what you call terminology function, MSCs are now called as medicinal signaling cells. It is not a stromal cell in the terms whatever we have studied in our books. It is a medicinal signaling cell. So medicinal signaling cell means it has a capacity to change accordingly to the situation. And the same characteristic, when you talk about characteristic, when you talk about stromal cells of kidney, wherever the fibrosis is there, any part of the other, the characteristic feature of the CD73, CD44 and CD105 you will find the same. And that is the physiological pathological changes. Thank you.
Thank you.
Mellitus is a diverse view in the recent advances in stem cell therapy in the management of diabetes. Over to you, Dr. Lee.
Thank you very much for inviting me to your meeting. My talk is cell therapy for diabetes type 2. As we know, there are two types of diabetes, type 1 and type 2. And type 2 diabetes occupy around 95% and most common in people over 40 years old. According to some research, in 2019, 462 million individuals affected by diabetic type 2. It means around 6% of $693 million by 2045. Per year can be attributed to diabetes alone. You can see trend of diabetes type 2. About pathophysiology of diabetes type 2, two important factors of diabetic type 2 pathophysiology are B cell dysfunction, lead to decrease of insulin secretion and insulin resistant. You can see the pathophysiology of diabetic 2 with this diagram, with this picture. For classic treatment, we have different treatment for diabetes type 2. For example, improve our diets, perform regular exercise to maintain healthy weight, and use medication to control blood sugar, and self-management to modify our lifestyle. With those treatment, we can decrease, we can maintain, we can reach to normal blood glucose. But not only like that, because many people don't respond well to those treatment. And one treatment is common in Canada and some other center is pancreatic islet transplantation. You can see, you can harvest pancreatic islet from cadaverous, and then we obtain the pancreatic islet and infuse to the patient. Recently, cell therapy was considered a promising treatment for diabetes type 2. You can see that especially mesenchymal stem cell, you can see they can increase the sensitivity to insulin in liver, in muscle, so they can increase glucose uptake, and by then they can decrease blood glucose level. And especially they can differentiate to B cell, and also they can decrease B cell apoptosis, so they can increase insulin secretion and decrease blood glucose level. Why we need stem cell therapy for diabetes? Because the current therapy have many limitations. For islet cell transplantation, we don't have enough donor, and patients have to use anti-resistant medication for life. For insulin injection, patients don't like comfortable to have injectable insulin every day, and for long time use of insulin, they can cause insulin resistance. That is why we have to find a new method in treatment for diabetes type 2, and stem cell based therapy is considered a promising treatment. We can have mesenchymal stem cell from different sources, from umbilical cord blood, from umbilical cord tissue, from bone marrow, from adipose, and from dental pulp. They also use embryonic cell and iPSC. Those cells have not been applied in human, but many study to use those cells in animal with good outcome. We can talk about mechanism, stem cell activity for diabetes. It is stem cell, and they have different function to improve diabetes type 2. They can inhibit the activity of immune cell or to secrete insulin, and they can increase the glucose uptake of liver and muscle. There are many clinical trials using umbilical mesenchymal. Possible for stem cell therapy using umbilical cord blood. In 2020, Dynam, Kassem, et al. Performed a meta-analysis study. They analyzed 6 studies with 172 patients, including 71 control and 74 patients. They conclude that the umbilical cord mesenchymal stem cell significantly improve HbA1c and C-peptide level, as well as daily insulin requirement. In contrast, they found that UCB, umbilical cord blood mononuclear cell, doesn't change the glucose level. For autologous bone marrow MSC, one study performed by Anil Hansali et al. In 2014, they have 21 patients with 11 who receive autologous bone marrow MSC and 10 patients as control. They follow patients for 12 weeks. For interventional group, they receive autologous bone marrow MSC 2 types, and they found that insulin reduction in intervention group, the insulin reduction, insulin injection dose can decrease 66.7% versus control decrease only 32.1%, and 10% in intervention group maintain HbA1c less than 7%. We performed one study to use bone marrow mesenchymal stem cell for diabetic type 2. And this study was carried out from December 2017 to February 2019 at Thai City International Hospital in Hanoi, Vietnam. 15 patients received bone marrow mesenchymal stem cell via intravenous infusion, and 15 patients received bone marrow mesenchymal stem cell via dorsal pancreatic artery. Inclusion criteria: person aged from 18 years old and older, both sex, and with the HbA1c level less than 9.0% and FBC less than 10 millimole lead. And those are inclusion criteria. For intervention, we collected 35 ml of bone marrow, and then the bone marrow mononuclear cell was collected and punctured under cyno-free and condition to expand the bone marrow MSC population, the release criteria and stem cell quality are accepted according to ISCT regulation. 15% receive stem cell by intravenous route and 15% receive stem cell by intra-arterial administration. We measure the adverse event and also the effectiveness by blood glucose level, HbA1c level, C-peptide, and patient quality of life, and also the insulin dosage which patient receive. You can see about the characteristic of patient at baseline. There is between two groups, different, and the duration of diabetes less than 10 years and more than 10 years in both groups, and also BMI less than 23 kilogram per square meter and more than 23 kilogram per square meter, and also HbA1c, FBC, and C-peptide at baseline. About the early and severe adverse event, we didn't observe any severe adverse event, and we had some adverse event, but they are very minor. For example, hyperglycemia, hypoglycemia, abdominal pain, splenomegaly, vomit, headache, hypertension, but all of them was resolved spontaneously or with the medicament. What about outcome? We can see changes in the HbA1c, fasting blood glucose, and C-peptide over time in different groups. And here we divide patient based on the duration of diabetes, so BMI. And you can see with the patient with the duration less than 10 years and BMI less than 23, you can see the difference between two groups was significantly. About HbA1c and also fasting blood glucose, you can see, and also C-peptide. So, patient with the BMI less than 23 and the duration of diabetes less than 10 years old, they responded well to the cell therapy. On contrary, the patient with the BMI more than 23 and the duration more than 10 years didn't respond well to cell therapy. We can conclude that the short-term therapeutic effect
see the slides.
So this is why very inconvenient.
Data copies. I will see my slides. Okay. Right on. कद आटला टी टाइम
एक आधा हाफ एन आवर चाहिए.
basics and clinical application. The last topic for today is autologous bone marrow derived osteoblast and osteonecrosis of head of femur. The speaker for today is Ms. Professor Muhammad Khamar Azam. I'm proud to introduce him. He's a professor and head of orthopedic surgery at All India Institute of Medical Sciences, Rishikesh. He has his education from Assam, Aligarh. He practiced orthopedic surgery overseas for more than 10 years. His special interest has been orthopedic trauma, arthroplasty and sport injuries. He has many national and international publications to his name. Osteonecrosis has been, osteonecrosis of head of femur is a very disabling condition which usually hit patients in young age and no cure. I will add to this, post-COVID it has been much more because of the steroid abuse. Now we understand that there is a chance we can cure these young patients with stem cell. Please welcome Professor Azam, and I hand over the mic to him for the session.
Thank you very much for the nice introduction. So thanks once again for the nice introduction. And the very purpose of coming here was primarily to see Hyderabad, meet the organizing team, meet my mentor Professor Sadar, and of course few friends from Hyderabad. And सब पीछे बैठे हैं, उनको देख के मुझे वहाँ का बकाला याद आ जाता है. Last night we had some good food here, which was very much like Mediterranean food also, that mandi and everything. So thank you for all the hospitalities. So I hope, so coming to the topic, regenerative medicine, by now we know that therapeutic application of stem cells is regenerative medicine for all practical purpose, and it is definitely an emerging field, and to improve the health and quality of life by restoring what is damaged and by maintaining and enhancing functions of tissues and organs. If these questions come to, I think this question is already addressed by many of the presenters here, but still to re-emphasize, stem cell therapy is not anything new. If we look at this slide, which is a busy slide of course, in 1950s, that is 70 years back, 70 years before, first successful transplantation of an identical twin was done in a leukemia patient. Then in 1990, which is again 30 years back, bone marrow transplantation technique was expanded very successfully and in a very large, massive scale. And it is last 3 years, 3 decades, that a lot of publications are taking place and a lot of clinical applications in every field is happening. Just to emphasize the magnitude of research which is ongoing, there are 3,000 clinical trials are running in US and European countries at the moment on cancer, use of stem cells in cancer therapy. Sorry, I think, okay, you are moving with me. Yeah. Next, that's good. So, but still, if we want to measure, where do we stand in the ladder of success? Then these are the questions being posed to us, even by the people, when we face people, or our patients, or even in the literature. Whether stem cell therapy is a hype or there is some hope in this, whether stem cell therapy and regenerative medicine is a myth or a reality. And the reasons are, there are many challenges which we need to overcome actually. And the challenges are, if we start from here, we still perhaps not very clear, at least the clinicians are not very clear, that which particular cell lineage is more suitable for a particular purpose. And then there is a lack of uniform protocol how to differentiate these cells to the desired cell population. What should be the number or amount of the cell population which we want? And what are the bioreactive molecules, cytokines and growth factors required to get exactly what we desire, that is the terminal cells. Similarly, when we deliver it, we still don't know, are we delivering the right amount in the right place, or we are not able to deliver it. And if we are able to deliver it in the right place, the microenvironment there, is it helping the osteoblast cells to cells which are expanded to the clinician again perhaps is not practiced very well. And finally, what is the fate of those stem cells which we inject in the body, whether they continue to proliferate to the teratogenic level or not, we don't know yet. So there are challenges which we need to face. Now, coming to the topic which is given to me, that is autologous bone marrow derived osteoblast in the management of avascular necrosis of femoral head. Autologous, as we know, those who are not from our field or who are juniors, taking the cell from the same human body and transplanting in the same one, that is autologous. Now, bone marrow derived osteoblast. So, we have been talking about mesenchymal stem cells. Now, there are some literatures which suggest that the terminal cell like osteoblasts, if given in the avascular necrosis area, perhaps they are doing a better job. So, the study and the topic that we did was osteoblasts, not mesenchymal stem cells. And avascular necrosis of the femoral head. That is a situation where the femoral head has got terminal blood supplies. So the blood supply doesn't come from many arteries. There is one artery which keeps on branching and they end there. So for one reason or the other, the reason can be vascular or the reason can be some medical problems also or over steroid use. If the vascular supply ends, that particular bone starts dying, which we call necrosis. So we want to see how this stem cells application help in this kind of disease. The first and foremost challenge that we face is early diagnosis of patients. So now a young patient, say 28 years male, presents to us with this X-ray and complaining of vague groin pain. So there are hundreds of reasons for that pain. So majority of the time what happens is we prescribe some NSAIDs and tell the patient to follow up in the OPD. If he is temporarily improved, they don't come to us. So the early time, that usually we miss. Now even if these patients come rightly, timely, and we are able to diagnose them in the early stage, we don't yet know exact way to treat this patient in an attempt to arrest the progress of the disease. For example, of course, non-medical treatments like initial treatment options like non-surgical in terms of lifestyle modifications and weight reductions are important. We start on medications, right? We start on medications like bisphosphonate for the purpose of anti-osteoclastic activity, prostacyclin to improve the blood supply, or the statins to reduce the fatty tissues. Similarly, we have hyperbaric oxygen chambers nowadays. So these hyperbaric oxygen chambers, which were used for sea divers earlier. So what happens is in that chamber, if you put the patient, then the pressure of the atmosphere is 3-4 times more than the normal atmospheric pressure. And when the pressure of the atmosphere is more, this oxygen available in the atmosphere, they actually dissolve in the blood. So even if the arteries are blocked, this blood circulation, that is the serum, not the RBC part, they carry the oxygen to the area. So that is another conservative mode of therapy. Should I stop with it? Because there are some photographs there. Next slide, please. Now coming to the surgical treatment options. The first person, Ficat and Arlett, who gave the diagnosis and first time the diagnosis and treatment of avascular necrosis of the femoral head, he gave the concept of core decompression. Now core decompression means, because this is a medical term, core decompression means that necrotic area under C-arm or fluoroscopy, we target that and remove that necrotic area. So by removing that necrotic area, what we are doing is we are decompressing that compartment. As a result, the blood flow increases, and that blood flow causes union of that area. So that is core decompression. Now subsequently, people tried core decompression with bone graft. Then people started core decompression with vascularized bone graft. And nowadays the trend is comes subsequently. The other mode of treatments were osteotomy, where what happens is you derotate, because this is the damaged area, which is the wet bedding area. So surgically what you do is, I think it's the previous, yeah, you derotate that area. So now the wet bedding is happening in the good part, not in the bad part. So the patient gets relief. But all these treatments options delays the definitive treatment. These are methods to delay the replacement in a way. So the most popular still, particularly in advanced people, is replacement. It can be replacement like this, different names, or total hip replacement, because it gives quick relief to the patient. And now the surgeons propagate, but that because of the improved design of the implants, improved technique, as well as improved biomaterial, the survival rate promised is 30 to 40 years. So this is very popular. But then this is not a treatment in a way. If this disease is happening to somebody who is in 30s, he is going to get revision and perhaps re-revision. So we need to find a solution. And the surgeons now look towards the stem cells as a hope that perhaps this is promising. Yes. So I also started my journey on mesenchymal stem cells with Professor Sadar. The first study I was directly involved and we got it published. The second study I was involved in the discussion, but I was not in that place. But both these studies were in the sickle cell patients, which is actually a different kind of group of patients. But still, we will share our experience. So what we did, clearance. So what we did is, photographs is not coming. I think there's some problem there. Can you move to the next slide, please? Yeah, this one. Right. So we aspirate the bone marrow from the anterior iliac crest. So we just put 2 centimeters behind the tip of the iliac crest here, so that we don't damage the nerve. There is one important nerve here. Then we aspirate around 10 milliliter. I think we aspirated 10 cc of that. And next slide, please. So we had a very good lab in Saudi Arabia. We would send that to one of the person. He was from Hyderabad himself. I remember, Prof. Huh? No. Anyway, so he actually, I don't know this methodology. So he expanded it, he isolated it, then he expanded the osteoblasts, and then he confirmed that the terminal cell that we are giving you is osteoblast. Next slide, please. Yeah. So again, something is missing, but anyway. So he did a test. So why I'm telling you this is because when we inject something to the patient, we should know, are we getting the desired cells or not? So that was confirmed. Next slide, please. Next slide. Right. Now we had expanded cells. So we took 10 million of them. 10 million cells were taken. Patient was taken to the OT for the second time. Now under CR exposure, that is the fluoroscopy. I think next slide, just click on. Yes. So this is under the image. So we have a X-ray type of machines there. We target the same area, we drill over it, and after drilling, we injected that 1 cc of sample of the cells. Next please. And the result was very encouraging. Actually, the first study that we showed, it was just for 6 months or 9 months. Professor Sadat continued with the study and he recruited 86 patients. Now, out of these 86 patients, Harris-Hippie score. Harris-Hippie scoring is a score for amount of pain. When the score is less, that is the patient has more pain. So it is slightly reversed. When the score is less, the patient has more pain. So the Harris-Hippie scoring, which was done after 6 months, significantly improved from 40 when the MRI was also done to all these patients. So we found that in the MRI, there was significant amount of healing was obvious in all the cases. Now this was the first case, this was second case, next please. Right, on this, next one. Okay, so I showed you MRI of 3 cases back. So I just brought here our first 3 patients where the MRI as well as the pain scoring system was much better and encouraging. So it was the first study and next please. Yes. So the results were encouraging and we concluded, or rather Professor Sadat concluded, that osteoblast transplantation has great potential in the healing of avascular necrosis. Complete recovery was observed in 86% of patients. Being minimally invasive procedure, it facilitates early recovery. So these were the conclusion. Now the question is, next please. One more. Now the question is actually, this was our finding. So when we do something, there is always a possibility of some kind of bias. For example, the selection bias can be there. The amount of follow-up was 2 years only. So those were the issues. So we cannot just say that we did this 80 patients and the results are satisfactory or so it's wonderful thing. We can't say that. So for that we have to go and see what the literature says. So I brought here 2 literature. This one is published in 2020. Now in this literature, what they have compared is core decompression alone with core decompression and bone marrow, expanded bone marrow cells, mesenchymal stem cells. And they had, this meta-analysis was of 13 randomized control tracks where 619 patients and 855 hits were included. And they found that the pain score has significantly improved in those patients where core decompression was combined with mesenchymal stem cells. But when they analyzed, right, they found that all these 13 studies had a very less number of patients in them. Some had 12, some had 18, some 20, some 35, or some had more. So, and the selection bias was there. So still we can't be very sure, okay, what we are, and the follow-up was for only 18 months, 2 years, 2.5 years, maximum 4 years. So it was not very conclusive. Then there is another publications where again it is in 2023 March, so it is just last month, where again they compared core decompression with stem cells and core decompression alone. Now, so they compiled all the studies which were published between 2011 to 2020. Here 920 hips were included. Now, when they analyzed with the forest plot, in terms of hip pain, core decompression with mesenchymal group had significantly better pain relief than those groups who had only core decompression. But look next. Here, this is an interesting finding actually. Okay, now different studies use, some use 10 to the power 5 number of cells, some use 10 to the power 8 number of cells, some people use 10 to the power 9 number of cells. But here they found that those who are having a range of 10 to the power 5 to 6, these patients are doing better than those who are having 10 to the power 9 cells. So that means it is not important that you give a lot of cells. So there has to be some optimum number. So majority of them agreed that it is 10 to the power 5 cells, which is perhaps therapeutically better. Now the third point is, see, this is very interesting. Whether treatment with mesenchymal stem cells change the conversion rate to total hip arthroplasty. So because that is the ultimate concern, can we change it? So there was no change much, no significant change. There was change, but not a very significant amount of change. That means we have not yet achieved the goal which we desire to achieve. Because 2 years delay is perhaps, if you are investing 2 lakhs rupees in this procedure, and in 2 lakh you can do total hip arthroplasty also today. So that means in terms of finance, perhaps we didn't achieve the goal. That was the conclusion of this study. Again, they found that there are different type of biases in the selection of the patients, etc. So we come to the last couple of slides. scaffolds or different biomaterials will further help delivering the stem cells to the right place. That is one thing. So we will have a scaffold, we can mix the mesenchymal stem cells there, we can deliver it to that place. Now what will it do? It will do a couple of things. Number one, delivery is in the target place, they will void the space, thereby giving some mechanical support in the beginning, and finally they have their own osteogenic and angiogenic properties. So maybe in future, stem cell therapy will require help or collaboration with the tissue engineering principles. Another thing which I find, because those who is hiposcopy, we have all heard about this arthroscope, endoscope, laparoscope. So we will put the scope inside, and along with the fluoroscopy image and the arthroscopy image, we can exactly localize the place where the disease is, and we can give the deliver the stem cells there. So perhaps the surgeons will have to do a couple of things. Right. Coming to the take-home messages. So I feel that is the question I was asking, that cell type does matter and the cell number. So we will have to fix that. Right. Yeah. And finally, this is the last message, that there is no doubt that stem cell therapy is the reality forward, but we have to move in a cautious way. For the patients, the caution they have to exercise is that promotional materials on the website that this therapy is safe and immediately or imminently available is not very correct. Unrealistically high expectations burst that bubble. On the clinician and researcher side, everybody wants to come with something very dramatic good results. So the drive to be the first to provide cell lines could compromise safety and lead this technology into the realm of quackery. That's a possibility. Desperation and urgency cannot be an excuse of bad science. Finally, stem cell therapy needs to be nurtured safely and methodically to provide real benefit to the patients in future. Thank you very much.
Thank you, Professor.
Thank you, sir.
Thank you, Professor Azam. It was an excellent insight, actually, and very importantly, you were sticking to the time. So it was, you have completed exactly in 20 minutes. There was an excellent session with he has started with the ladder of where we are into the orthopedic part, especially taking into consideration avascular necrosis. As a clinician, it was very clear and crispy to understand every aspect how it happened. You started excellently with depicting the idiopathogenesis of the avian part, and then bridged about the normal clinical and surgical approach with the latest stem cell and where we are both in terms of the financial aspect as well as the clinical outcome. So any questions for the professor?
You will have to answer your question, I think.
Suchanda.
Sir, earlier in orthopedic surgery they are using bone marrow MSc, and now come to the bone marrow MSc. So what do you think, which is better, or we just say both are equally good? What's your experience with that?
No, actually, see, honestly speaking, we don't have much clinical experience. Right? We don't have much clinical experience. So very difficult question. If you ask my experience, so we have used or we have seen very close persons like Professor Das using mesenchymal stem cells in early stages. But if you ask my exposure, so I can't say which is good and which is not so good.
No, so any comparison you feel that or to explain to us?
No, I can't say because we have not done any randomization kind of thing that we have used this and also this in this number of patients. So I can say that actually. So if anybody has that answer, can please answer that. Sir.
I have one
question.
No, question.
Question.
आपने जो ऑक्सीजन चैम्बर में बैठने की बात करी, थोड़ा सा उसके अंदर because right now majority of the whatever disease is being managed towards the normaxic and hypoxic condition, and HIF factor 1 is becoming a main target for a number of main
HIF factor?
say, no, it should be correct, that now this oxygen chamber will help a lot in many of the chronic conditions?
See, it is being used these days, and the hypothesis is very strong. Hypothesis is strong because it is based on a very strong, well-established principle that if you increase the pressure, for example, the Coca-Cola can that we open, so for those students maybe who are not familiar with that principle, so when we compress the air or increase the pressure, the air will dissolve in the solution. So when you increase the atmospheric pressure, now vessels are blocked. So vessels are blocked. What we have is a plasma. So plasma is a solution. So when you increase the atmospheric pressure to 3 times, 4 times, the oxygen gets dissolved more and more in the plasma. Normally the plasma carries only 3%. Rest of the oxygen is carried by 97% of the oxygen is carried by the RBC. So when you increase the pressure more and more, maybe up to 20% of the oxygen is being dissolved in the plasma. So now they are going and they are supplying that. And patients are getting benefit of that we have seen. So pain relief. The question is not that. The problem is we don't know how long this pain relief lasts, number one. And how many hyperbaric oxygen therapy cycles are to be given. So in the literature now it ranges from 20 cycles to 100 cycles. And 100 cycles are very difficult. So whatever experience that we have in our system is that we give 20 hyperbaric oxygen therapy cycles.
For the neuropathic pains?
No, because what happens is, because now whenever this happens, the AVN, one is blood vessels are compressed actually. There is no clot in the blood vessels. It is compressed. Compressed because of the fatty tissues and the edema. So when you put this patient there, oxygenation improves, edema decreases. Right? And it gives pain relief. So in fact, couple of doctors also, even one orthopedic doctor had actually this AVN, and especially after Corona actually, honestly, we had a lot of, early stage diagnosed AVN. So it is helping. How much it is helping?
No, not only just talking about I'm just thinking about the basis of any disease, not only the
Yes.
basis of any disease you talk, diabetes, any disease. The oxygen concentration
Right.
in a terminal vessels or in a deep tissue, in a niche, goes down.
Yes.
And the gradient which comes there, hypoxic condition, that makes a killing of that particular.
Right, very correct.
That is. But the only thing is that we don't have any parameter to it. At the moment you talk about this therapy, I have started assessing HIF RNA script.
Okay.
And so I just studied one of the pulmonology in the sleep apnea. After that in the morning I told do the HIF. And in sepsis, it is very established.
Right.
HIF factor will certainly go high.
Exactly.
So this therapy, what I think, is it a regular type of a treatment in your?
Not very common. It is coming up actually. Okay, hyperbaric oxygen therapy, as you said, in our clinical practice is very helpful in the bad wounds or cases which we did the debridement.
Was for about 2 years. Once they enroll, today that you need total knee replacement, they have to wait for 2 years because of the government institution. They cannot be done next day or day after. So they said, okay, he is waiting. Just for his satisfaction, let us give the MSc. And they found only 6.9% came back after that for a total knee replacement. The rest of them were far better. Next slide. So this was another, in our trial, we did publish in 2021 in the Advances of Orthopedics, where a small number of the team, not a large cohort group. Next slide please. Here, open label, single dose, clinical trial, chondrocytes, 5 million, and we got all the approvals and everything, and then we started the trial. Next slide please. Now we went by the visual analog scale. We modified the knee score, because you see in the new score from the Europe and the Ontario scores are different, because they say the lady has to walk 2 blocks, go up the stairs, whether she can carry the grocery bag. In some had to modify the scoring system. Next slide, please. And we found that the age again was 45, 70 years. We had 12 months, at least 12 months on non-steroidal drugs, no injection of steroids, no hyaluronic acid, no PRP, nothing of that sort. Very neat virgin knee joint. Next slide, please. And then we find after all that exclusion criteria, next slide. The first patients, for this randomization we did, what they did was we put envelopes. One had a control group, the other had a study group, and whoever picked up the envelope, they got it. We very clearly, most of them were employees of the universities, who were faculty staff, technical staff. This is how we selected them. Next slide, please. Bone marrow aspiration standard protocol, chondrocyte differentiation was done. Next slide. And then we injected directly in the clinic. We didn't go anywhere else. We injected in the clinic. Next slide, please. And I have the testimonials of some of them in Arabic. I cannot show it here, you will not understand. They said even after 3 months of the injections, they went to some other orthopedic surgeon and a radiologist to see how the x-rays and MRI looked like. They said, no, this is not your knee joint. This is somebody else. This is the improvement of someone. Now, this is the comparison. Age group was very, very similar. And then the quality of life, all parameters which we tested were highly significantly improved in the study group. Next slide, please. Next slide. This is all going on. So what we confirmed that 5 million autologous bone marrow derived chondrocytes was efficient in reducing the symptoms and improving the functional score and betterment of quality of life. This is what the patients want. Lot of patients, when they reach this stage, they even go in for arthroscopic joint washout and injections. So this avoided most of the other procedures. Next slide, please. So we believe that a single link definitely will save cost, and at least a follow-up of about 5 to 6 years, we can postpone their surgery. It is worth doing it. Next slide, please. Now, there were 2 different lectures I combined together so that for the saving of the time. The annual incidence of meniscus injuries is about 60 to 70 per 100,000. This is in general. Next slide, please. Which involve, and now orthopedic surgeons probably are more interested in doing meniscus surgery because a lot of young people have sports injuries. Next slide, please. So here in this one, studies found that the patient with meniscal injuries have Haysen cartilage wear, and we know very well that if part of the meniscus is removed or damaged, very early they set in and have osteoarthritis. That is the reason why meniscectomies is not being done anymore. Next slide, please. So surgical management is still the same, but still people want to preserve the meniscus as much as possible. Next slide, please. Therapies are focused to regenerate, repair or replace the injured meniscus and restore to its native function. This is what the aim is now for meniscus injury treatment. Next slide, please. Now, again here, why after a meniscus injury, stem cells reach the joint? As I told earlier in one of the discussions that if you have an injury, a skin injury, then the brain cytokines will direct the ectoderm to produce cells to go directly to the site of the injury. So they, after acute meniscus injuries, they aspirated the synovial fluid and they found that the MSCs were very high, suggesting that the injury has caused the mesenchymal stem cells to arrive to the joint. Next slide, please. Now, this is a very interesting study which was done in US. After medial meniscectomy, they gave allogenic MSCs to see what happens to the knee joints. 2 groups were there. Next slide, please. And they found that they gave talking about the number of cells. In this group, they gave up to 150 million cells, 50 million cells, and 10 million cells. 6 million cells. They found those patients who had 6 million cells had a fresh new meniscus from the meniscectomy which was done before. This was not reported before, that a meniscus which was removed can regrow under the influence of the stem cells. This was the study, I think it's published in 2014 in JBJ's American one. So this definitely says that even if you are removing part of the meniscus and then injecting stem cells, the remaining part of the meniscus will regrow. Next slide, please. Now, this is another short 15 meniscus injuries which we published in Trends of Medicine in 2018. Next slide, please. Here again, outcome, next slide. Keep going. The standard procedure, we did the same thing. We aspirated the bone marrow, removed the chondrocytes. Next slide. One more. Go ahead. Okay. Now here, for the people to understand, if you see a meniscus in the lateral view, we get a red zone which has got plenty of blood supply. You don't do anything, still the meniscus will heal with rest. Then we have in between a red and white zone. There is a chance the meniscus will heal by itself. And there is a white zone where the chances of the meniscus healing on itself is zero. The reason why I am showing it to you, that this area will not heal, whatever you do. But under the influence of stem cell therapy, under the influence of chondrocytes, I will show you the results, our own results. Next slide, please. If you see this meniscus, this is the break, this area where the pointers are there. This is in the white zone. And then post-injection, if you see, the meniscus is completely healed. This is the meniscus. It should be a break here somewhere as healed. That means under the influence of chondrocytes, even in a white zone where there is no blood supply, the meniscus can heal. Next slide, please. Next slide. Okay. So in this study again we found that 90 days post-injection the pain was completely gone, and then 4 months, because we usually did 4 months MRI post-injection because we know the terminal cell has a lifespan of 120 days, and we found that post-injection MRI showed the healing of the meniscus with good thickness. I tell you, in our own institution, one of the meniscus injuries patient went for an MRI. The radiologist.
My topic here, I'm very thankful to Prasad, he brought me here for this lecture. My topic is stem cell therapy for therapeutic spinal cord injury and where we are today. I'm Dr. Ehsan Siddiqui from King George Medical University, Lucknow. Next slide, please. According to the global burden of the disease report, the age standard rate of spinal cord injury is about 13 per 100,000. And total load on the society is almost 2 crore 70 lakh people. It is a huge number globally. The catastrophic nature of these injuries, coupled with the ongoing chronic nature of the symptoms, means that the spinal cord injury survivors can expect to incur significant expenses. First year cost is about $5,18,000 and paraplegia cost about $1,13,000 per year. So it is very costly to treat, and this is a burden on the society. Next, please. Can we treat patients with spinal cord injury? Unfortunately, there is no way to reverse damage to the spinal cord. Although some neurological functions might be regained, most patients with the initial complete lesions have severe irreversible neurological impairment. cell-based and stem cell-based therapies are recognized as the promising candidates for the promote to the functional recovery. We need functional recovery in patients of the spinal cord injury. Most of these studies are animal studies. Now we started to do some that Japan is allowing to do the studies on the human beings. So transplantation of the stem cell, in particularly neurological stem cell, progenitor cells is promising. These cells have these potentials to differentiate into the nerve tissue cells, able to enhance endogenous regeneration and prevent the development of the inflammatory process. What we need, so we need these things. So here, again, this Professor Sadab and I was also there with them when they started the study in Saudi Arabia. So what they did, this study provides strong evidence in the support of the transplantation of the embryonic stem cells and autologous bone marrow derived neurocyte can improve the functional recovery of the iatrogenic spinal cord injury. The transplanted cell shows a beneficial therapy effect when compared to the control group. Next slide, please. Here again, the other study by Park, published in 2012, they said that less is known about the effect of autologous mesenchymal stem cell in human beings. Other studies there were there in animals. So again, please next slide please. Autologous mesenchymal stem cells were harvested from the iliac bone of the each patient. In people model, he started this study. In each patient of the expected to culture of the 4 weeks, he cultured for the 4 weeks, the MCS, mesenchymal stem cells, he implanted 8 million while directly injected into the spinal cord, and 4 million cells were injected into the intradural space for the intent patient. What result he got? Out of 6 patients showed motor power improvement of the upper extremities at 6-month follow-up. And 3 patients showed gradual improvement in the activities of the daily living. MRI in these patients shows decrease in the cavity size and appearance of the fiber like low signal intensity peaks. They also shows electrophysiological improvement in these patients. All 10 patients did not experience any permanent complication. This is also important. If you are not gaining any benefit, there should not be any harm. Then again, in these patients, 3 of these 10 patients of the spinal cord injury who were directly injected with autologous MCS shows improvement in the motor power of the upper extremities and in activities of the daily living. Then this leads to the meta-analysis. This meta-analysis, please next time, this meta-analysis, this opened the door to study further where we can go. This matter is published by the Roberta in 2023. A literature search methodology he used between 2000 to 2023. All relevant data like MBase, the Cochrane Center Register for the Control of the Track, Cochrane database of the Systemic Review, Midline, Science Citations Index, and Scopus and WebScience, all these things he studied. And he removed the study from there. Keywords what he typed: traumatic spinal cord injury and stem cell therapy. What he find? These criteria for the NSA include the articles involved, case report and clinical trial. 2 things he started to study. The authors evaluated all the data independently and there were no discrepancy in the paper selected for the review. Analysis between the report outcome of each cell type was performed according to the gold standard efficacy outcome measures like the ACN impairment scale and motor and sensory score. What is the ACN? This is the American Society for the Spinal Cord Injury. And what result he got? Currently, 1,149 clinical trials focused on the improvement of the outcome of the spinal cord injury were registered in the US National Library of the Medicine at www.clinical 5 different types of the cell he studies: autologous, analogous bone marrow, autologous adipose tissues, umbilical and MCS and neurocytes, Schwann cells, olfactory, initiating cells with or without scaffold are used. He used these 5 cells. The number of the cells injected were between 5 to 20 million. These sites injected were from 1 to 3 sites he injected these cells. The sites were intrathecal, venous and arterial SS. These are the sites, what he got here. Therapeutic preparation. These are the 5 cells what he studied, and he found these cells are responsible for these things. Next slide, please. Here, if he has seen the sensory improvement, here he finds when they use these cells, there is a definite sensory improvement in the patient. And at the next one, in motor, there was also improvement in this patient. Please, the next slide one. On total 58 studies, improvement in Asian score where he found the random effect model-based meta-analysis shows that these systems can improve motor function in almost 49 to 50% patient. What he concluded, the overall improvement of the Asian impairment scale, grade convergence rate, here the improvement was almost 40% of the transplanted patient, which surpasses the spontaneous improvement rate expected for the complete chronic CSI patient with 1 year post-injury. Compared to the efficacy and safety of the cell transplanted in spinal cord injury, here is the other. What he was, this paper was published by the Zhu et al., published in 2022, where the similar result he was also found. 44 eligible trials involving 1,260 patients investigating 6 treatments of the same 5 cells he studied. The patient with CSI, SCI, who received transplantation of the microphages and all these things improved disease. Then in 2019, Japan passed law allowing stem cell clinics. In that time, some 3,700 treatments have been given. In Japan, clinicians can extract stem cell from bone marrow and from the skin biopsy. The protocol for the trial, patient selected CSI is less than 12 months. If you are going for a trial, then you have to select your patient, and there should be a recent MRI and electrophysiological study to be there, so that you can know whether the patient is going to get benefit or not. Then in first week, 5 million neurocyte and 5 million mesenchymal stem cells should be given intrathecally. Then in second week, 5 million neurocyte and 5 million mesenchymal stromal cell intravenously one has to give. In third week, 5 million neurocyte and 5 million mesenchymal stromal cells intrathecally one has to give. What is the cost of this thing? This is very costly otherwise. The patient selection with stem cell injury, spinal cord injury, less than 12 months should be there. Autologous bone marrow dried stem cell costs about 10,000 rupees in Indian currency. And 3 injections of 5 million neurocyte cost about 3 lakhs. 3 injections of 5 million mesenchymal stem cell again cost almost 3 lakhs. So total cost should be around 6 lakhs and 1,000 rupees. But it is worth or not, one has to judge it. Whether the patient should be on wheelchair bound for whole life or one has to expend this money. What are the conclusion? The stem cell therapy plays a definite role in the reversal of traumatic spinal cord injury. Thank you. We have done few cases of this stem cell implantation in spinal cord injury, but the result, I don't know. It will be Professor Sadat and Professor Azam, they are knowing better whether they are getting good result or. after the injury.
So do you think surgery is required because you have to manage that first, then you go for stem cell therapy for nerve regeneration?
Yes.
So surgery is required.
For nerve regeneration, one fixation is very important.
Yes, that's
Fixation is very important. And one has to look after how much the surgery it is. What is the extent of surgery? If it is involving whole cord, partially cord, or there is chances of recovery, inflammation and how much, then accordingly one has to go. The fixation should be done as soon as possible. And these things within, here it is saying that 1 year time. So one has to look after fixation, after decreasing inflammation, how much improvement is there, and you can go for or prepare the patient for all these things. And better Dr. Azam will tell.
So I think, you see, all fractures which are unstable have to be fixed. Where is Dr. Iftikhar? Oh, yes. So, he's a spine surgeon. All patients, as a standard procedure, what we used to do, have to have surgery, which are unstable fractures. A stable fracture usually does not very rarely it happens sciura, where there is no fracture as such, but still there will be a neurological injury. So in cases where you have a fracture which is unstable, most of the time it will be unstable, it has to be fixed, it has to be stabilized. Then within 1 year, see, some of these will recover. It's only a confusion it will recover. And some of them will not recover. That is the reason why if you delay the injection of the cells after scar formation, then there is no chance of healing. So the criteria is before 12 months. You have to inject.
So is it possible that during surgery you can implant the cells?
Then it has to be allogenic.
Yeah, definitely.
And it has to be it has to be available on in-house on the shelf.
That possibility there during
Yeah,
surgery.
definitely. But you see, if it is available in the site, yes. Usually people don't keep it.
And also the nerve regeneration is a very tricky thing. So did you find after stem cell that is really the nerve regeneration? Because
This meta-analysis which came in the brain showed very clearly that 40 to 50% of them they recovered completely, at least 1 to 2 levels of the Asia score.
I'll say we'll call it the patients today. It's a very interesting and rich academic program. I think so. We're all very thankful to Dr. Sadar for conducting this today here in Hyderabad. And because of scarcity of time, I would like to wind up and call all the faculty over here for a valedictory function. First, I would like to call Ms. Jhalak Neema onto the stage, please. Next, I would like to call Dr. Anjum Mahmood onto the stage, please. Next, Professor Aleem Ahmad Khan. Next, Dr. Ehrar Ahmad Feroz. Next, I would like to call Dr. Lipi Singh onto the stage, please. Next, I would like to call Professor Muhammad Azam onto the stage, please. Siddiqui onto the stage